Oh my goodness. Listen, my friends, we have to have sense of humor. Sense of humor these days because life is just chaotic. Am I right? Am I right? You betcha I am right. All right. So if I'm looking up here, I'm looking at Facebook. YouTube is on. Hallelujah. Okay. All right. All right. So, thank you. Heidi says, "How are you?" I'm doing quite well today. I have to say, I feel pretty good today. My IC is very very good. Getting ready to film some new videos. Getting ready to do some new TikToks. Going to do some IC TikToks. How does that sound? And I'm hoping that you guys will maybe do some TikToks too. IC Awareness Month is coming in September. We've got to get started. We got to start doing some things. And obviously, this year with COVID, it's going to be very, very different. I'm going to tell you that we are going to be doing a series of very good live events with featuring, I hope, some of the best doctors in the world on IC. Some group meetings where you will be able to come in and watch and hear what these guys have to say and these women have to say. And so hopefully I will have an announcement in the next 2 weeks about what we're going to be doing with that. I'm quite excited about that. You know, years ago when I started the IC network, and I guess, you know what, I should really introduce myself for anybody who's new. My name is Jill Osborne. I am the president and founder of the Interstitial Cystitis Network. I'm the longest serving IC support group leader in the United States at this point in time. I started the IC network I started my first support group in September of 1993 from my bed because I could barely walk. My IC was so bad. And when I had a doctor tell me, you will forever be a burden on your family, you will forever have severe pain, get used to it, this is your life. I needed to hear that. As cruel as that was, I went, wait a second. Wait a second. This was at an emergency room. I was at the ER 2 days in a row because my pain was so bad. And he again said, you will forever be a burden on your family. And I just like woke up. It's like, wait a second. Wait a second, you son of a gun. Wait. I have 3 college degrees. I have an award from the White House. I will prove you wrong. How dare you say that to me? And it was at that moment that I started fighting. And I need you to fight too, because you know what? He was wrong. I haven't had that pain in 15, 20 years now. I don't live with pain every day anymore like I used to. Healing is possible. Healing is possible. But we have variants of IC, we have subtypes of IC. And so back in the old days, everybody was given Elmiron. Everybody was given DMSO, silver nitrate, chlorpactin, because there was this perception, of course, that everybody had a bladder wall issue. Now we know that that's simply not true. Now we know that there are structures outside of the bladder that can also cause bladder symptoms, that the bladder is the secondary victim of another issue that might be going on. And so my purpose in doing these meetings is to make you so strong, so knowledgeable, so informed that you can take charge of your medical care, that you can walk into any doctor's office with confidence to know what the right questions are going to be, to get them to look at you in a different way. That is our goal here. Empowerment, enlightenment. You pay them, pay you. You pay them. Ultimately, in the end, you are the boss. And I need you to walk into every doctor's appointment informed, confident, and most importantly, knowledgeable. Please do not be one of those patients who walks in, bursts into tears, and says, I don't care what you do, do anything. For God's sake, do not do that. Do not do that. Because what they could do an old therapy. They could strip your bladder wall off with silver nitrate or chlorpactin, even though that hasn't been an IC therapy for 15 years. I was working like 2 weeks ago with somebody who had that done. I couldn't believe it. It's not even listed as a therapy for IC, yet there's still doctors doing old time stuff. The theory back then was if you strip the bladder wall off, then a new whole bladder would grow. But we know that that's not necessarily true. You know, and if your bladder wall does happen to be injured, like from chemotherapy, the last thing we want to do is make the injury bigger, which is what those old therapies do. So you got to walk in ready to talk, pros and cons, different treatment options. This is about you. This is about your preparation. This is about your knowledge level. This is about you You've got to be willing to learn about stuff. And, I have to say, it's interesting. I mean, I've been a support group leader for a long time. I've worked with thousands of patients in 25 years. Thousands of patients in 25 years. I'm not kidding. For those of you who called me, you already know that I answer the phone. I will spend an hour or more with patients at a time who are calling in crisis, like I did yesterday. As a matter of fact, somebody called yesterday and I answered the phone. Go figure, on a Saturday. So, I don't want you to walk into your doctor's office and say you got IC. I want you to walk into your doctor's office and talk about your symptoms. Okay, doc, listen, I got pain on my left side that gets worse when I have a bowel movement. Or I've got pain on my right side that comes and goes, or it's electrical. Or, doc, I've got this weird vibration when I sit down. Or, doc, why is it that I can sleep okay, but as soon as I sit on the side of my bed, it hurts? Or doc, you know what? I haven't 5 years. I'm up every 15 minutes. Can you help me understand why? Doc, I got blood in my urine. What's that all about? Can you please help me understand why there's blood in my urine? Because certainly that's not normal. Our goal is to get them to study your pelvis. And not just your bladder, your pelvis. Remember, Western medicine fails to a certain degree for pelvic pain syndromes because doctors stay in their box. Doctors stay in their specialty. And so if you're peeing a lot, the odds are you're going to go to a urologist, and the urologist is going to say, oh, maybe you got a bladder infection. They throw antibiotics at you. Or might say, hey, you got overactive bladder. Throw out overactive bladder medication at you. Those don't work. Then they say, maybe you got IC. They give you IC meds like Elmiron. Don't really work for some of you. Not for all of you, but for some of you. Why? Why would a bladder therapy not work? Because maybe your fundamental problem really isn't your bladder. Maybe your fundamental problem is outside of your bladder. Maybe, for example, the woman I was working with yesterday, fibroid tumors. If you have a fibroid tumor, it can be pushing on your bladder. That can be an issue. Endometriosis. You could have endometriosis on your bladder wall. You could have a tailbone injury. Did you fall and hurt yourself? Were you an athlete? Were you an ice skater, gymnast, ballerina, football player, wrestler, anything that involved repetitive pelvic traumas? Ironman athlete. Worked with another Ironman athlete 2 weeks ago. Fascinating. If you're sitting on a bike for miles and miles and miles and miles over time, that bike seat is going to push up right into your tender bits. The bike seat is going to push up right into your nerves, but between your legs, your pudendal nerves. But it's also going to put extra strain and pressure on your pelvic floor muscles, those deep, difficult muscles. It would be nice if these muscles were on the outside. It would be nice if the muscle was right here, because then we would know it really sucks when the muscle's deep inside your body. And that's where your pelvic floor is. Some of you have a chronic infection, like a chronic fungal infection. Do you flare when you eat sugar? Do you flare when you eat carbs? That's one of the signs of a chronic fungal infection. Now, why do I bring that up? This has been one of my big issues for the last couple of years, because there's back in the old days, there was a very big group of people who believed that IC was chronic bacterial infection. And for decades now, it's like antibiotic, 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 right? Over and over and over again, not understanding the terrible toll that antibiotics take on your body, that they destroy good bacteria, bad bacteria. That's why you get C. diff. That's why you get candida fungal infections, right? And so it's incredibly interesting that our own National Institutes of Health MAP Research Network has made some critical discoveries in the last 5 years. Critical discovery number one is, guess what? You're flaring, have candida infections in your urine. You got candida in your bladder. And that's not just one study, that's multiple studies. Multiple studies have now found an overgrowth of fungus in the urine of some IC patients, especially when you're flaring. Isn't that interesting? And it's even more interesting when you think about our history, because here you've got frequency, urgency, pressure, pain. You go to the urologist goes, hey, must be a bladder infection. It's like, yeah, it is a bladder infection. But guess what? Antibiotics don't work. Antibiotics make it worse because antibiotics kill the good bacteria that normally control fungus. So for some of you, fungal infections are at play. For others, and I talked about this 2 weeks ago, viral infections are at play. So we knew, and I've talked about this before, 4 to 5 years ago, it was first the IC researchers in Europe who kept finding virus in some patients, especially patients with Hunner's lesions. They found the polyoma BK virus. Polyoma BK, now we're not talking sexually transmitted disease here, guys. You don't. That. Polyoma BK is a normal part of a human virome. Those are the viruses that live in the human body. We all have that one already. And it's normally silent. It normally doesn't do anything unless you get immune compromised. If you get immune compromised, that virus turns on. And it has been long known to cause hemorrhagic cystitis, bleeding. There are multiple research studies that have found polyoma BK in patients with hemorrhagic cystitis. So we know the polyoma BK virus can infect the bladder wall. We know that. Also in Europe, they found Epstein-Barr. There's been some discussion about human papillomavirus and herpes virus, right? But interestingly, the Americans were very quiet about this. And, I'm like sitting here going, guys, this is so interesting. This is so interesting. Can we get an American to comment on the European results? And I was really baffled why they hadn't done that. Well, now I know why, because they were doing their own study. And it was a big study. It's a really big study. And it was also National Institutes of Health MAP Research Network study where they group of patients who have been participating in multiple research centers across the country, urine samples over time from these patients. And they took a sample of those patients and they started studying those urine samples. So they had a urine sample, their first urine sample, and then I think it was a urine sample at 6 months, and then a urine sample at 1 year, and then a urine sample that they got at home during a flare, and then a urine sample not during flare. And they, again, were using something called next generation urine testing, which we've all been talking about. This is the way to identify fungus and viruses in your blood, in your urine, in addition to bacteria. What do you think they found? Polyomavirus. 20% of patients, or 20% of the samples that they looked at had a polyoma BK virus, and they found 2 different polyoma viruses. They found the BK virus and the JC virus. And so there is absolutely no doubt at this point in time that a small group of you may have a viral infection in your bladder. And this is good news. I'm telling you guys, seriously, this is good news. Though virus is a dirty word right now, obviously, but at least we know what the hell it is for some of you. We now have new ways of looking at this. We have new ways of trying to figure out why you, the IC patient, are not responding to therapy. Listen, the American Urology Association released guidelines for IC in 2011. There are 2 key concepts in this. Number 1, if you're not responding to therapy, or if you're getting worse rather than better, it's time to step back. Like, oh, okay, wait. Let's not spend 20 years doing Elmiron if you're not getting any results from Elmiron. Stop for a moment. Take a step back. Wait a second. Wait. Could we have missed something? It's possible. It's absolutely possible. We don't want to accept status quo. If you are suffering, we need a new, fresh look at your pelvis, because your pelvis is a small confined area. Think about your pelvis for a moment. Okay, your pelvis, hip bone to hip bone, right? Front to back, hip bone to hip bone, is the anchor of the human body. It carries the weight of your torso. It also deflects, or it doesn't deflect, it absorbs the stresses when you walk. If you stumble, the stresses and strains of that stumbling go right up your legs into your pelvis. The pelvis is also a small confined area that is a communication channel. Nerves from your brain down your spine, through your pelvis, down your legs. Blood vessels from your heart go through your pelvis and down your legs. And then, of course, inside your pelvis, you've got your organs. In addition to the bladder, we've got your bowel, and we've got your reproductive organs, right? There's a lot happening in the pelvis. And if there's one thing we know, is that they don't operate in isolation. They influence each other. There's an important book every single one of you needs to get. And listen, this is free on Kindle Unlimited. Like, no excuses. This is about making you so knowledgeable that when you walk into that doctor's office, you can say, hey, you know what? I've got this thing right here. I'd like you to look at this. Could it be XYZ? This book is a masterclass in pelvic anatomy, and it's so easy to read. It is, I think, the best book ever written for us, ever. And he's the one who says, guys, you can't operate in isolation here. The organs affect the muscles. We call that a viscerosomatic reflex. So, okay, so let me give you two examples. When you let's talk about women for a moment. When you have your period, you have cramps. They hurt. Cramps are from muscles that are moving things along. It can also be your pelvic floor. If you're having bowel spasms, if you're a gentleman and you get hit in the you-know-whats, that intense pain from an organ is going to cause your muscles to get tight in a guarding reflex. Okay, you can't stop that. That is something completely outside of your control. We call that a viscerosomatic reflex. Okay, your viscera can affect your muscles. But the far more important question here for some of you also is, can muscles affect organs? And the answer is yes. And so there's also a big group of you whose symptoms began not because of infection, but because you got hurt. You got hurt. You fell on your tailbone. You fell on your hip. You had a baby and got a torn muscle. Maybe you were a victim of sexual abuse, which would be so sad. And I'm so sorry if that happened to you. Muscles that are injured become weak. They also develop trigger points, muscle knots. And think about it this way. When you fall, bam, what happens? You get a compression injury. The muscle fiber is compressed, but so is the blood vessel, and so is the nerve. How do we know the blood vessels get compressed and broken? Hello, you get a bruise. But so do the nerves. The nerves also get compressed. And inside that little nerve channel is a little tiny blood vessel that gets broken. And when that blood vessel gets broken, that nerve can't function normally. And you end up getting muscles changing nerves that then move up to the spinal cord, which then move down to the bladder, and the bladder also ends up having problems. There's a long, complex explanation about that. The nerves get injured. They start releasing substance P. Substance P damages tissue. We start to see a deterioration of the bladder wall. Okay, so clearly, a lot of things can affect the bladder. And your job as a patient is to kind of start ruling stuff out and then try to figure out what's primary and what's secondary. When somebody calls and they talk to me, like the lady I was talking with yesterday, it's like, okay, my symptoms began 10 years ago. Okay, what was going on 10 years ago? Well, I was in a car accident, or I had a baby, or I started chemo. There's usually some sort of event. Many of you, even though you might not have verbalized it, you can point to some sort of triggering event. You have a hunch. It's like, what do you think did it? Was it a traveling? Was it an accident? Was it just something funky like that? Sometimes that's your first clue. Um, um, and then again, and it's so interesting. I gotta say, it's so interesting because so many of you don't tell your doctor about traumas. You don't. You're like focusing on frequency, urgency. It's like, yeah, but you know what? You got hit by a car, right? You broke your pelvis, right? Important. Your urologist needs to know that. Or maybe you had a third-degree muscle tear. That's important. Your doctor needs to know that. And so you, my friends, it's an incredible anatomical mystery to be solved. And the great news here is we're no longer throwing people under the bus of saying you've got a bladder wall issue. We're now really understanding nuance. We're understanding really clear, specific diagnoses that will focus the right therapy for your specific presentation of IC. It's really, really interesting. So like I'm super excited right now. I'm really, really excited. Why? Because so many patients are getting better now that they solve the mystery. And again, this book is going to help you at least start to understand your body. And I want you to read it with the perspective of, did anything happen? Can you remember anything that could have happened? Right? Okay. So anyway, well, listen, you know me, I always can just go on and talk about stuff. Normally when I do these meetings, I usually do 30 minutes to an hour of me talking about stuff. I got a few more things I want to talk about. And then we start taking your questions, and then we will be switching over to Zoom, to a Zoom meeting probably in an hour or so that you also can talk to me and ask your questions there. But let me give you the good news. So here, hold on a sec. I got to go to this computer for a moment. I have so many windows open on my computer. It's ridiculous. Hold on. Here we go. Okay. So it worked, my friends. It worked. Our citizens petition to the FDA to get the label of Elmiron changed worked. The FDA has now required a labeling change for Elmiron that talks about the risk of eye damage. We've been working on this for almost 2 years. I'm the one I'm the one who broke that story. I'll know that probably already. I'm the one who told the IC patient community about the new research that showed that Elmiron could cause pigmentary maculopathy. We did a big research study. We presented the data to the FDA over a year ago. Their initial response was that they couldn't be bothered, but we have had so many more research studies proving retinal damage, progressive retinal damage, at least in one case, with one case study from Harvard, that they really couldn't ignore it anymore. And so I wanted to read you this warning. This is one of the biggest warnings I have ever seen on a medicine. I've got a degree in pharmacology. I mean, at least in the IC community. So the new label for Elmiron in the United States now says, warning, retinal pigmentary changes Pigmentary changes in the retina reported in the literature as pigmentary maculopathy have been identified with the long-term use of Elmiron. Although most of these cases occurred after 3 years of use or longer, cases have been seen with a shorter duration of use. While the etiology is unclear, cumulative dose appears to be a risk factor. Okay, so the first thing you got to understand about this warning is that they're saying that, yeah, the 3-year mark appears to be a critical mark, but some patients are reporting eye damage earlier than 3 years. And in our own research study that we did on the IC Network on patient survey, we had patients reporting changes in their eyes in the first year. In the first year. Okay, let's go to the second paragraph. Visual symptoms in the reported cases included difficulty reading, slow adjustment to lower reduced light environments, and blurred vision. The visual consequences of these pigmentary changes are not fully characterized. Caution should be used in patients with retinal pigment changes from other causes in which examination findings may confound the appropriate diagnosis, follow-up, and treatment. A detailed ophthalmologic history should be obtained in all patients prior to starting treatment with Elmiron. If there is a family history of hereditary pattern dystrophy, genetic testing should be considered. For patients with pre-existing ophthalmologic conditions, a comprehensive baseline retinal examination, including color fundoscopic photography, ocular coherence tomography, is recommended prior to starting therapy. A baseline retinal examination is suggested for all patients within 6 months of starting Elmiron treatment. That's important, guys, because they need to be able to see what your retina looked like before you started the treatment and then what your retina looks like afterwards. If pigmentary changes in the retina development, then the risks and benefits of continuing treatment should be reevaluated, since these changes may be irreversible. Irreversible. Follow-up should be continued, given that retinal and vision changes may progress even after the cessation of treatment. Okay, so this is huge. Not only do we have a good warning that will now let people know the risks of using Elmiron, but they're being really blunt about what they're saying. It can be short-term use, less than 3 years. It can be, let's see, permanent and irreversible, right? There was one other in there. Okay. All right. Huge, huge. So at least now, patients, before you think about taking Elmiron, you will be able to know the risks. And now, no more should a doctor say this is not real. There is now a legitimate warning from the FDA on the label. Debbie Hall says, what happens in a cystoscopy? In a cystoscopy, I call it a looky-loo. What they're going to do is they're going to numb your urethra, stick a scope in, and take a look. 5 minutes, in and out. And what a cystoscopy allows them to do is kind of a cursory examination of your bladder wall. It's not big, it's not invasive, it shouldn't damage your bladder in any way. They're not stretching your bladder in any way. The cool thing about having a cystoscopy done, I've had 2 done, is it will let them look for something like bladder stones. And if you got a bladder stone, that can also be a cause of IC, or cause of bladder wall irritation. And so having a looky-loo is not a problem. Now, the issue with having a cysto is anytime they insert something into your urethra, they're stretching your urethra, and it's going to hurt. It's going to hurt. Fern says, I'm on for today. Is this an old broadcast? No, this is a new broadcast. This is a brand new broadcast as of today. I am talking live to you right now from my home office in Santa Rosa, California, where we have a new red flag fire warning. So if we have a fire, I'm going to run. Okay. You can come print out that information on our website to give to your doctors, but they should just be able to pull the label. I've got an article on this that you can print out right on our website that you can hand to them. And also, for our members, Is this the right one? Okay. In our latest magazine, the IC Optimist magazine, which is our member magazine for the IC network, I have an extensive interview with the lead attorney who has now filed 4 federal lawsuits against Johnson & Johnson, Janssen Pharmaceutical, on behalf of patients who have eye issues. And so you can hear straight from the horse's mouth, for lack of a better term, or straight from the attorney's mouth about what they're trying to do with these lawsuits. Okay, and the points of contention in the lawsuits. The biggest point of contention in the Elmiron lawsuits is the lack of notification. Did the company know that there were eye issues that they did not educate us all about? And the answer is probably. Because what the Emory Eye researchers did when they published their first study is they found an old clinical trial with Elmiron from back before 1996, which actually in 4 years of use, the trial lasted about 4 years, they did note several eye complications that, including retinal hemorrhaging is one, that interestingly didn't end up in the patient education materials. It's like they found it in the study, but in the patient education materials and the brochures that they give to patients, the eye issues are not there. And the answer is why? Why? Now, getting back to your question about cystoscopy, if they're doing a hydrodistension with cystoscopy, that's a whole nother bag of worms here, because that's done in an operating room. You are always under anesthesia for that. You should never be awake for that. I actually had an accidental hydrodistension awake, and I will tell you, I was hysterical with pain. It was done by a radiologist who overfilled my bladder during an examination. She got fired over it. Deserved it because she ignored my doctor's instructions. But generally what they do is they will put you under with something like propofol, a very, very light anesthetic so that you can't feel it. Propofol is ideal for a urological procedure like that because it kicks in quickly and it gets out of your system very, very quickly. And so they will knock you out, and then they will fill your bladder with fluid. Stretch your bladder out a little bit, drain it out, fill it in again with some more fluid, keep it in there, maybe drain it out again, and then they insert a cystoscope to take a closer look at the bladder wall. Now, that used to be the gold standard diagnostic test for IC. However, it is no longer that because we now know, again, from other research studies, that when you stretch the bladder wall gets red anyway. The bladder wall can have wounds on it just from the procedure itself. And so a hydrodistension is no longer a gold standard test required for the diagnosis of IC. However, they do recommend that you do it if your diagnosis is in doubt, because it can look for abnormalities like, do you have endometriosis coming through your bladder wall? Do you have a stitch from a prior surgery coming through your bladder wall? Is there something else odd? Do you have Hunner's lesions? So there comes a point in time, again, where if you're not getting better or if you have blood in your urine, having a hydrodistension with cystoscopy to just allow somebody to freaking look at your bladder is important. You know, there's a very, very interesting case. You can't let fear stop you. Do not let fear stop you. We had a lady, I've told her story several times, who was totally afraid to have a cystoscopy, just totally afraid. And so for years and years and years, she wouldn't let anybody look in her bladder. She just wouldn't do it. When she finally got to the point where she just wasn't getting any better, and she said, okay, you can look. What do you think they found? A bladder stone, a giant bladder stone. Now, a bladder stone is normally composed of calcium and oxalate, and it often happens when you get really dehydrated. And in her case, her symptoms started when she was traveling and not drinking water. And ended up, obviously, she got super, super dehydrated. She grew a huge kidney stone that ended up in her bladder, didn't pass through her urethra. It just got bigger and bigger and bigger. The thing about bladder stones is that they're really sharp. They hurt. They have very, very sharp edges, and they are also covered with bacteria. And so for years and years and years, she had a sharp object floating in her urine, scratching her bladder wall. When they got rid of it, what do you think happened? her symptoms went away. Bladder stones are very common around the world. So having a cystoscopy, giving somebody an opportunity to look if you're not responding to treatment is important, because they might find something really simple, really, really simple, like a bladder stone. Let's see here. Let me go down to YouTube. So you guys, I am simulcasting right now live on Facebook and YouTube. And so if I'm looking up here, I'm looking at Facebook. If I'm looking down here, I'm looking at YouTube. Hello, Donna. Hi, Barbara. Hello, Marianne from Sweden. Hello, 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 hello. Hi, Deb. Hi, Barb. Barb says, "How are you, Jill?" I'm feeling pretty perky today. I gotta say, I'm feeling pretty perky and optimistic. All right, let's get back to Facebook here. Melody says, "I'm still cramping from my hydrodistension with cystoscopy a week ago. Cramps are pretty bad. Using azo for cramping and taking pain meds. I can't remember this cramping this bad." All right, so Melody, you have to understand that the most common complication after having a hydrodistension with cystoscopy is an infection. Many patients end up with bladder infections after they have a hydro. So if you find that your symptoms are getting progressively worse, or you're just not healing, you need to call your doctor and get your urine tested, because it wouldn't surprise me at all if you could have picked up what we call a nosocomial infection, an infection from the hospital. Generally, hydrodistension with cystoscopy, if it's done the correct way, which is low pressure, short duration, as opposed to high pressure, long duration, which is what they used to do years ago. They used to really stretch out the bladder and leave it in there for a long period of time. We now know that that's pretty damaging. So the American Urology Association says do a low pressure, short duration to minimize trauma to the bladder. So I had one 3 years ago, and it didn't mess me up in any way. Granted, I had it during a hysterectomy too, so that's a whole nother story. Melody says, "I'm scheduled for cysto in July. I'm anxious about it. Do you think yours was worth it? Are you having..." Okay, now listen, cystoscopy, I'm all about information, data, hard data. I don't like guessing, I like facts. And there comes a time when, especially if you're in pain, you just need to have somebody look at it. I mean, if it were me and I'm in pain, or if there's something wrong, I want somebody to look at it. Please look at it and tell me what can possibly be going on here. And so as long as it's done in a very, very gentle way, a plain in-office cysto is really not that big of a deal. But if it's a hydrodistension with cystoscopy, please come on over to our website and read the section on that. And most importantly, you need to have a discussion with your doctor about what is the doctor's plans if they find a Hunner's lesion. Because if they find a Hunner's lesion, they should treat it at that time. You don't walk out of you should not be walking out of a hydrodistension diagnosed with a Hunner's lesion that has not been treated. Lesions need to be treated, and they recommend they be treated at the time. And what I find is many patients, I was working with one again earlier this week. She had a lot of Hunner's lesions. They'd never been treated. She didn't even know they could be treated. And so you need to have that discussion. What do you intend to do when you find a lesion? Are you going to cauterize it? Are you going to inject it with a steroid? What are your plans? And if the doctor says, "I'm not going to do anything," I honestly would back away from that and say, well, I would like to work with somebody who could treat something that they find, if they find something like that. Otherwise, you'll have to have another hydrodistension to treat it with somebody else. It's tricky. Cindy says, "Just wanted to let you know I appreciate your dedication. I can finally take a low acid multivitamin. I have a pelvic ultrasound tomorrow to know more about my IC." Good. I'm glad you can. I hope that you're taking Bladder Smart. Bladder Smart is a low acid vitamin that I take, and it's right. Where is it? You know, IC patients, if you've got bladder wall damage and your bladder wall is sensitive to food, then you probably already figured out that taking a multivitamin hurts. Why? Because like Centrum 1 a day, their source of vitamin C is usually ascorbic acid, which is a very strong irritating acid. And so you have to use a buffered vitamin C. and then have other ingredients in it that can help reduce some of the acid levels. So the multivitamin that we suggest is Bladder Smart, and you can find that in the IC Network store. I'm the one who actually proposed the first low acid vitamin 15 years ago with another company, and that was Multirite. And so the very first low acid vitamin on the market was actually my idea, and it was Multirite. And we sold it for many, many years, but the pill was just very, very big and it was hard to swallow. And so I asked this company if they would create us another option. And this is much easier. It's a capsule. It's much, much easier on the body. Let's see. So for those of you who might remember the horse pill, oh darn it, these are not openable. Oh, that's because here we go. I want to show you what it looks like so you can see. So this multivitamin is just a capsule. You can take 1 to 3 a day. And so again, especially, I'm not a huge fan of vitamins. I'm not a huge fan of taking vitamins every day. I don't usually take it every day. I'll take it 3 or 4 times a week because I do know my diet's a little bit limited. I like this because it's super easy to swallow, but it's a really, really good formula. So anyway, there you go. Bladder Smart, if you're looking for a low acid vitamin. Annie says, I signed up as a new member. Can't wait to read the magazines. You can, if you signed up, Annie, you just have to log into your account in our store and go to your member page, and all those magazines are right there for you to download and read. You have to set up an account in the IC Network store to become a subscriber and to get our magazine. You're in a pain flare every day, tight pelvic floor muscles, widespread pain due to polyneuropathy, diagnosed, tried everything using PEA a week, only haven't noticed a difference. Physical therapy too painful right now, had a hysterectomy taking, girl, you are going through some stuff, and you sound like me 3 years ago when I had my hysterectomy. So, number one on the PEA, palmitoethanolamide, we have a research study from Europe that shows that palmitoethanolamide and resveratrol is remarkably successful at reducing the pain of IC. And that was presented at the 2019 American Urology Association Conference for IC. And so now we have some supplements that have the potential of also helping to reduce some of your pain and discomfort. And let me get those for you. Well, I'll just pull these down. You can see I reorganized my office a little bit. So Bladder Builder is a chondroitin-based supplement to help protect the bladder wall, but it also has PEA in it and collagen and a few other things. And then just for straight hope, what the research study shows would be some pain relief. There's Peora, which is just palmitoethanolamide and resveratrol. All right. So again, supported in a research. What began all this was a research study presented from Italy last year, which showed that at 3 months, 87% of patients using PEA had a significant reduction in their pain, and at 6 months, every patient using it had a significant reduction in their pain, and 25% were pain-free. And so to have something, for those of you who have been taken off of your pain meds, to have something that might help reduce some of your pain is wonderful. It's just wonderful. Heidi says she flares when she exercises. So what does that tell us? It tells us that your muscles are flaring. When you're exercising, you're moving muscles. And so the odds are you're probably having a bit of a pelvic floor flare. Especially if you're doing things that are bouncing. When you've got pelvic floor issues, you've got to be really careful about the exercise that you're doing. We don't want you to do things where your hips go like this. So running is not ideal. Stairmaster is not ideal. Elliptical would be great. Rowing would be great. Swimming would be great. but keeping your hips level when you're exercising is important. And we have a video over on our website that gives you tips on exercise with pelvic pain. Also, by the way, oh, you know what? Where is it? I don't know if you guys have seen this. New Dawn Pilates for pelvic pain. New Dawn Pilates for pelvic pain by Jenny Buttaccio. And again, cleaning out my office, found an extra copy of this. Let's give this as a giveaway. Let's do it right now. Okay, so the hard part here is that Facebook and YouTube are slightly delayed. Okay, so if you stick out to the end and you do a Zoom meet and you come to our Zoom meeting, I'm going to be giving away this, okay? So that's going to be one of our giveaways. All righty. Cindy says, how do I know if my multivitamins are acidic? All you need to do is look at the ingredients, look at vitamin C, and if it says ascorbic acid, it's acidic. Jeannie says, I've been diagnosed with Hunner's lesions. Is there any new help for this? Yes, Jeannie, there is. So in addition to cauterizing and lasering lesions, we now know the lesion with a steroid, triamcinolone, that equally as good and effective as cauterizing it, but it doesn't have any scar tissue. We also know that hyperbaric oxygen therapy is working well for patients with Hunner's lesions. And of course, Liris, Liris, is the first treatment in history that has healed Hunner's lesions in 2 weeks. Unfortunately, Allergan shelved it. It is not available at this time. When it does become available, I will be the first to let you know. But also understand too, Jeannie, that it was the researchers in Europe who connected Hunner's lesions with viruses. And so specifically the polyoma BK virus and the Epstein-Barr virus. And so it would be very, very interesting, in my opinion, to think about having a next generation urine test to see if you might have a viral infection, because if you do, you could potentially use an antiviral therapy. And in either the article I wrote or in the research study we're referring to, they actually cite antiviral therapy and its use in IC patients, and they had success with it. So that would be something else that would be very, very interesting to find out. Debbie says, let's see. So Debbie is responding to Rachel about different types of cystoscopes, that there's flexible or rigid. And in fact, there's also a very specific cystoscope that they can use during a regular cysto that can identify a Hunner's lesion. The name is escaping me right now. It's not commonly available. So Debbie says here, there are two types, flexible, rigid. I had a rigid, so it was under general anesthesia. For me, they filled the bladder to max capacity. They looked beneath the camera and then took biopsies, which was brilliant because a visual inspection alone showed no evidence of IC, but the biopsy showed gag layer changes confirming IC. I have not had a flexible, but it's still okay. So Debbie, in the viral study, they talked specifically about how viruses have been linked to changes in the bladder wall. And if you come on over to our website and read that, I think you will find that very interesting. So, you know, when you just say, okay, yeah, proof of IC, now we got to figure out really what's there. IC is a grab bag diagnosis, guys. Lots of people are called IC for lots of different things. Now we got to figure out why your bladder wall has changed. Is it estrogen atrophy? Is it a chronic viral infection, a chronic fungal infection, something else going on? You don't just stop at IC. You have to look beneath that to try to figure that out. Melody says, who is this book by? This book was by Jerome Weiss. Jerome Weiss, you can get this in our store. Maureen says, I'm having intense pain from your stimulator, chronic IC, fibromyalgia, awful. Maureen, listen, if you're having intense pain from an inner stem, you need to call your doctor immediately. Call the company tomorrow. Let them know it should not hurt. If it hurts, there's a problem. They got to fix it. You should not be living with any pain coming from your stimulator. If you are having pain from your stimulator, that says that there's a malfunction. If you're being shocked, that's a sign that the lead might have disconnected or the lead might have broken. Or sometimes, not sometimes, frequently, there can be infections, deep tissue MRSA infections. And so you got to let somebody know right away that you got pain from your stimulator, okay? Dina says, has anybody tried cacao? I've heard such good things about it, but I know most of us can't have chocolate. It's a great question. I don't think nobody's ever really studied it. I simply won't touch chocolate because it gives me terrible spasms. Fawad says, respected madam, it's clear that when the bladder irritates us, it's painful and it affects our mental health. You better believe it does. Hey, listen, there's nothing worse than having terrible pain and not understanding why, and then having doctors say it's all in your head. It absolutely can affect us physically, mentally, and emotionally. No doubt about it. It's hard. You have never worked as hard as you are working right now. And what really sucks about it is that here you are struggling with a flare, potentially a really, really big flare, and you just want somebody to come in and take over and make your appointments and make it go away. And it's very, very hard that you've got to be your own advocate and do that work when you're having a flare. But you do. If you're sitting at home suffering in silence and nothing is getting better, that's when you got to start reading. You got to start asking yourself different questions. You got to make an appointment, get yourself up out of your bed, into the car, and get to a doctor and start talking to them. Because for all we know, you could have been 10 years on bladder therapies only to discover after the fact that it's a freaking fibroid tumor pushing against your bladder. If you're not getting better, the AUA says, take a step back. Let's revisit the diagnosis. Let's make sure nothing else is going on. And the other thing that we consistently see is a lot of you are told you got tight muscles, but you're not doing anything about it. Listen, the problem with tight muscles is it restricts blood flow to your bladder. It restricts blood flow to a lot of different things. It's very hard for your bladder to be healthy if it doesn't have good oxygenation and good nutrition. And so you might go to physical therapy once, twice, 3 times, and then give up. For God's sake, don't do that. Don't do that. You have to be on top of your muscle health. And one of the things that this book talks about, this is the thing that makes Dr. Weiss so good, is that, he became a master at muscle manipulation. He could fix trigger points. He could have patients walking out of his clinic with normal muscles and normal nerves. What really baffled him is, why did the trigger point come back in exactly the same spot a month later, or 2 weeks later, or 6 months later? Why was the muscles always messed up in the same spot over and over and over again? And he introduces the concept of a mechanical injury. You know what? If your muscles are always tight, we have to look at bones, because muscles are attached to bones, right? Muscles hold, your body lives with bones and muscles and fascia and all that sort of stuff. If you have a bad hip, if you got one hip higher than the other, that would put strain on your pelvic floor. If you've got one leg longer than the other, that would put strain on your pelvic floor. If you've got scoliosis, if your tailbone healed crookedly and it's bent to the side instead of in the center, or has a weird arch in it, or straight when it's, if it just heals incorrectly, if you've broken a leg, the odds are the leg you broke is now shorter. So what does that do to your hips? Well, now your hips are slightly off. So when you walk, now you're walking like this. What does that do to your muscles? That strains that muscle on that side. The chapter in here that's going to blow your mind is a chapter on feet. Because if you're not walking normally, your knees are going to be weird, your hips are going to be weird, and it's going to be putting stress on your pelvic floor. And so if you have Morton's toe, Morton's neuroma, plantar fasciitis, shin splints, of which I have all of those, that could actually be the reason why you have long-term chronic pelvic floor pain. So what he found in his clinic is that 90% of the patients with recurring chronic pelvic floor tension had foot problems. And when they finally got the feet fixed and the patients were walking normally, what do you think happened? Their pelvic floor tension improved and they stopped flaring and their symptoms resolved. That's why it's so sad that people are continuing to say that IC is an incurable bladder condition. Because for some of you, it could be a curable muscle condition, a curable fungal infection, a treatable viral infection. There are lots of potential triggers for the symptoms that we associate with IC and the bladder. Hey, give me a moment. I'm just going to go start the Zoom meeting. Let me just open up Zoom for a moment. Because the best part of this, you guys, seriously, the best part of this is coming into Zoom, where you get to tell your story and ask questions personally. So hold on a sec. All right. All right. So I am just starting the Zoom meeting, and hold on a sec. Yes, I am using computer audio. All right. So we're not formally starting it, you guys. For those of you who come in, you're going to come into a waiting room, and I'm going to let you in. But let me just go ahead and post the invitation links into Facebook and YouTube, and you all can start coming on in. Elise said, that's very interesting. I have problems with my feet too. All right, YouTube, there's your invite to the Zoom meeting. Facebook, the thing about Facebook is I won't be able to scroll back. Debbie says, how I knew that the pelvic floor was all related was after my hip replacement. Oh my God, I thought they had operated on my vagina. I had to ice it for weeks. Girl, holy moly. Jennifer says, can you talk about nerve blocks? Sure. Nerve blocks are used really to diagnose pudendal neuralgia. And so if you've got electrical pain, searing pain, burning pain, or you've got numbness, you've got pricklies, you've got a vibration, anything at all like that, that signals that you might have a nerve entrapment, pudendal neuralgia, et cetera, et cetera. And so they would use a nerve block to diagnose that. Hi, Annie. Annie, I've got you off right now. I see you. All right. So Tabitha says, can one of the symptoms from pelvic floor be cramping very low above the pubic bone? Yeah. You know, if you ever strain too hard, you're having a bowel movement and you ever strain really, really hard and you kind of sore for a day or two or anything like that. Yeah, that's that. All right, Facebook, I'm going to hold on. I'm scrolling down. I'm putting your thing in. So you guys just got the invitation to the Zoom meeting. Terry says, hello on Facebook. I can see you. Hello, Terry. It's nice to see you. Nikki says, what next generation test do I order for pelvic pain, urgency, and burning? You can order just the typical urine test. If you go to bladderhealth.org, you can see that. Or you can order even the vaginal swab, just out of curiosity. Fern says, I live in Mercer County, New Jersey. I have seen a doctor at Cooper Medical Center. She told me to get a hold of. Oh, girl. Fern, we have a database right on our website. And so you can search, you just go over to icnetwork.org and you can search for that. Karen says, I pulled a muscle in my lower back since then my bladder has been on fire. Are they connected? Absolutely. They absolutely are connected because you've got psoas muscles that go up your lower back but are anchored deep down in your pelvis. Whenever I get low back pain, it's always my psoas muscle. So yeah, definitely, no doubt they're connected. Fern's having her pelvic floor in 2 days. Awesome. Is there anything you can do to help with pain after pelvic floor exam? Heat. Anything that will relax the muscle would be a really good way to go. And also, if she finds a tight muscle, what are the injections? They don't do injections into tight muscle at first. I mean, if they find a trigger point, they might do trigger point therapy where they inject a little numbing agent into it so that they can massage it out. And there are some cases with severe pain where they can basically inject Botox into it or severe tension. But don't worry about that. They're not going to do that for your first appointment. Maureen says, I asked my urologist about the next generation test. She flat out refused me, said I'm not covered for it. If you call Microgen, they will give you a referral to a doctor who will do it. Deborah, can I call for medication rather than email? You mean it's supplements? Yeah. If you're talking about us. Marlene says, can supplements or anything I can do at home to heal Hunter's lesions? Marlene, Hunter's lesions respond best to lesion-specific therapy, hon. Just lesion-specific therapy. So they're either going to inject it with a steroid. Deborah, can I call? They might cauterize it and hold on. Sound on. In terms of supplements, really, the best thing you can do is something that has chondroitin, which can help restore some of the integrity of the urothelial cells of the bladder wall, combined with something that might help reduce some of that pain, like Peora. So you could try Bladder Builder, or you could try Peora, but ultimately, in the end, there's no supplement that can heal a Hunter's lesion because we don't know what's causing your Hunter's lesion, right? Derek says, have been any developments for stem cell therapy in IC? The stem cell therapy was originally done out here in California at the California Stem Cell Center by Dr. Elliot Lander. The early study showed that what they did was stromal vascular faction, SVF. So they did liposuction, they pulled some fat, they mixed it all together, and the stem cells to create something called stromal vascular faction, or SVF. They then re-injected that into the patient, and what they found was that it was successful but not durable. And within 6 months, they usually had to do it again, okay? Somebody's asking about the new InterStem, the size of a piece of gum. Yeah, there are a couple of different companies now that that have new, slightly different neuromodulation devices. Annie, I don't remember the name of that one, but you know what I did? is I went over to the FDA database, the MOD database, to look at complications because ICA referred to a 3-year study testing this new one. And I saw that cross my desk at some point in time in the last couple of weeks. And so what do we do? What do we do when we hear something like that? You have to go over to the FDA database, the MOD database, like the old TV show, MOD, MAUDE. So Google MOD, FDA MOD. And the side effects were astonishing. There were many, many there. You have to understand with neuromodulation, the risk of side effect is very, very high. There are hundreds, if not thousands, of adverse events reported with InterStim and the other sacral neuromodulation methods. And the newer one, which was the rechargeable one, which is, I think, the one you're referring to, also had a lot of potential side effects. I'm going to do an article on it. I just haven't had time yet. Brittany says, do you have any suggestions for IC patients who want to have sex? I haven't had sex with my boyfriend since my symptoms started 4 months ago, and I'm depressed. Yes. Over on our website, icnetwork.org, we have a whole section on sex. A whole section on sex. And ultimately, in the end, you have to understand that if your muscles are tight, think about it this way. Here's your pelvis. You know, let me get my, what did I do with my ball here? Where is my therapy ball? Here, hold on a sec. Let me grab something. All right. All righty. Pelvis. Here's your pelvis. You have muscles that go from left to right. You have muscles that go from front to back. You've got muscles that go from low to high up into your back, right? What makes the pelvic floor especially challenging is it's the only major muscle group that also controls major bodily functions. So the pelvic floor basically has 3 holes. It's got a hole for urine around you, so your urethra. For women, it's got a hole for your vagina. And it's got a hole, there's a gap in it for your rectum, right? So here we have your pelvic floor muscles that are basically a woven basket of muscles that are basically wrapped around your urethra and your rectum and your vagina, etc. If your muscles are weak, what happens? So just pretend this is your bladder. If your muscles are weak, we start seeing things falling. We call this a prolapse. And there are women who one day they feel something, a ball, something hard coming out of their vagina. And that is because their muscles have become very, very weak. And I'm just letting more people into the Zoom meeting. Guys, I will repost the invitation to Zoom. I really hope you'll come on over. It's so fun. All right. So if your muscles are weak, things start to move in a bad direction. And if you catch it early enough, you should be able to do specific exercises to get those muscles toned again. But if your muscles are tight, it's hard to pee. The number one symptom of tight pelvic floor muscles is that when you go to urinate, you cannot relax your muscles easily. So you sit there for 5, 10, 15, 20, 30 seconds before you can relax enough to let your urine out, right? It's hard to have a bowel movement. And it's hard to have sex. If it's hard to let something out, it's equally hard to let something come inside. And so, Brittany, that usually one of the very, very first things we see with somebody who's got pain with intimacy is that they have very, very, very tight pelvic floor muscles. And pelvic floor physical therapy can fix that. It can fix that. It's very, very important that you have a proper pelvic floor assessment, and let's see what's going on with your pelvic floor. If your flare starts a couple of hours after sex, that is your pelvic floor. Now, in contrast, If you're having pain during sex, some of it can be positional. It might mean that you're using a position where the bladder is being directly pushed on and traumatized. So you've got to try different positions too. So come on over to the IC Network and go to our romance and intimacy section, and that might give you some suggestions there. Becky says, I've been on Bladder Builder for 6 months. My frequency has increased. Can you compare Elmiron to Bladder Builder? Also, is there anything via prescription so that insurance will pay? Well, so what's the rule? What's the rule here? If you're on any therapy and you start to have weird side effects, especially kind of milder, more subtle side effects, generally what they will do is they will suggest that you reduce the dose. So, and that's what Dr. Parsons said. That's what Dr. Parsons said. When somebody said, well, I have to be on Elmiron for the rest of my life, he said, no, we just need to figure out if it's helping you. How do we do that? By reducing the dose. And so it might be very interesting to reduce your dose of Bladder Builder a little bit, and see if that might be the source of your discomfort. We aren't seeing that. We just did a big survey of people taking Bladder Builder, and we're not really seeing people who have gotten worse. I mean, and I think the data was like 90%, 88%, 90, 92% of patients using Bladder Builder felt that their symptoms had improved. And I will try to collate that data too. It's not that I don't believe you. I absolutely do believe you, because we are all so freakily different. Elmiron is essentially a bladder coating. It's a chemical coating composed of pentose and polysulfate. Given the fact that Elmiron is now associated with eye disease, so what are your options? Well, rather than swallowing Elmiron, you could do an Elmiron bladder installation, where they just put it right into your bladder. And that's the best way to take Elmiron anyway, because you're not swallowing it. Most of it doesn't get destroyed by digestion. 100% of the medication arrives in your bladder to be functional. So, Becky, what you could do is you could ask your doctor for a rescue installation using Elmiron or using heparin. That would be interesting. Or there's no other pharmaceutical coating. You would really have to look instead at chondroitin-based supplements. We had a research study presented at the European Society for the Study of Bladder Pain and IC early this year before COVID, which showed that the most important ingredient for helping to restore the bladder wall is the integrity of the urothelial cells of the bladder wall is in fact chondroitin. And so using a chondroitin-based supplement, whether it be Bladder Builder, Bladder Rest, Cysto Protect, or Cysto Renew, would be ideal. Those are my best shots for you. We're all different. And yes, there are some people, I got an email from somebody today where Elmiron is the one that's the one that's working for her. So you've got to have a risk-benefit discussion with your doctor about it, and have your eyes checked. You may be part of the group of patients who don't have the retinal issue, and if that's the case, power to you. Then Elmiron might be viable for you. But if you start using Elmiron and your eyes start to change, it is important that you have a talk with your doctor about trying other things, because what we're finding, at least through Harvard, that in some patients, after you stop the medication, the eye damage progresses. Mary Jones says, the JC virus in which? The BK, B as in boy, K as in Kelly. Fern says, I've had many UTIs over the past 40 years and have developed allergic reactions to angioedema. Girl, I am so, so sorry. Terry says, does Medicare do next generation testing? The answer is yes, they do in some circumstances. It's just a little bit longer to do it. Getting reimbursed next generation testing, the companies might have to wait a year before they're reimbursed. But if you call microgendx.com, ask them. And the last time I talked to them about it, Medicare did pay for it. But I think it was in a very specific, rigid set of circumstances. Karen says, does next generation urine testing go by another name? Next generation DNA urine testing. Next generation DNA urine testing. So Karen said she had the next gen test. It came back showing lots of E. coli. The report showed which antibiotics the infection was resistant to. My doctor thought it was great. I had 2 rounds of antibiotics about a month apart. My bladder has been much, much better. That's wonderful. That's absolutely wonderful. That's what we like to see. Karen says, I'm going to have one next appointment. Awesome. 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 Beatrix says DMSO. Lee says, what do I think of DMSO, also known as RIMSO 50? It's really fallen out of favor in terms of a therapy for IC. You had one on June 5th and you ran a fever for 3 weeks after. So Lee, that's really disturbing. And I hope you told your doctor about that, because that speaks to sterile technique and or potentially, maybe contaminated RIMSO 50. You guys, if you're ever going to have DMSO, you always have to look at the bottle they're using and make sure it says RIMSO 50. It cannot say anything else but RIMSO 50. What's happened is Chinese manufacturers have been sending cheap, so DMSO is a byproduct of the paper industry, wood pulp industry. And so a tragedy struck when unscrupulous Chinese companies started marketing to compounding pharmacies here in the United States. Hey, we've got DMSO, buy it cheap by the barrel. And some pharmacies did. What they didn't know is it was industrial strength. And so these pharmacies then marketed to doctors and said, hey, you using DMSO? We got cheap DMSO for you. Buy it from us. And so they repackaged this industrial strength DMSO into small vials and made it look like RIMSO 50, even though it wasn't RIMSO 50. Sent it to doctors. So unfortunately, at least one office manager fell for the fax campaign. If anybody sells something by fax, you got to be concerned, right? So they sent out faxes saying cheap, affordable DMSO, and this one office manager bought it, didn't tell the doctor, because the vials look the same. The doctor used it and used it on a young patient, and it was industrial strength, and it dissolved her bladder. It dissolved her bladder in 30 minutes. And she had to have emergency reconstructive surgery. And that has happened a couple of times now. So the only DMSO that should go into your body is RIMSO, RIMSO 50. Look at the bottle. They've been warning people at the various urology conferences to be very careful about your source of DMSO. But in any case, it's just not used that often anymore anyway. So why? DMSO hurts. It has a lot of side effects, like you smell afterwards, it's garlic smell. We have research that shows that DMSO can cause irreversible muscle spasms. That's not a good thing. And it was replaced by rescue installations. Rescue installations make you feel better. They make you feel better. Joe says, is lichen sclerosis connected to ICM, suffering badly from both? Lichen sclerosis really is extreme neuroinflammation. It's sad that they use the word lichen because you start thinking like mold or fungus, but it's actually extreme neuroinflammation where your tissue turns white. And generally, lichen sclerosis is treated with clobetasol, a strong steroid. We don't really see a connection, quote unquote, between the bladder wall and lichen sclerosis. But if you have other nerve issues, then potentially that's the connection. All right, let me go down to, so you guys on Facebook, I'm going to post for you again the invite to the Zoom meeting. All right, YouTube, same thing. Holly on YouTube says, if Lyrica worked, does that mean that it's just nerves? Well, it certainly means that your nerves are involved. And that's one thing that Dr. Weiss says in this book. He believes that quite a few patients have more nerve involvement than they realize. And so in his workup with patients, what he assessed the skin, he looked for very clear signs of nerve involvement. So he looks at the skin, like for lichen sclerosis, and for changes in the tissue, changes in sensation, numbness, anything like that, which would all tell us that the nerves underneath the skin are also involved in some way. All right, guys. CM says, is it possible the next generation bacteria results could be your normal bacteria? Absolutely. It's going to tell you everything that's there. It is absolutely going to tell you good bacteria, bad bacteria. So if, for example, you come out of that with, what's the name of the common bacteria that women have in our vagina that's supposed lactobacillus? There's nothing to worry about. Beatrix says, Desert Harvest multivitamin irritates my bladder. Any other suggestions? Yeah. Absolutely. Do the original one. Do Bladder Smart. Bladder Smart does not have, remember, some people are intolerant to aloe. They just don't handle aloe well. It can give them gut distress. Bladder Smart does not have aloe in it. And this is based on the original formula that we put together 15 years ago. So the Desert Harvest multivitamin is very new, whereas this formula is the old formula. We just took out some extra minerals to make it smaller. But this is really the low acid multivitamin that we recommend, and it's over on the IC Network in our store. All right, it is time to go to Zoom. So for those of you on Facebook and YouTube, you're going to hear us. If you want to see us, then click on the Zoom link that I put, and you are absolutely welcome to join the meeting. And get used to it, because our big events are going to all be on Zoom. It does require you to download a little tiny piece, either an app if you're on an iPad or if you're on a desktop. Now, for those of you who are on Zoom, I'm looking at a doorway. Please remember that other people outside of Zoom are listening too. So please don't say something that you would not like the general public to know. If I happen to ask you a question that is embarrassing, you can just say, I would rather not answer that question, or can we talk offline about it? You guys remember, the IC Network is the only nonprofit, or I'm sorry, we're not a nonprofit. We are a health education company. We are the only support group that answers the phone, and we are more than happy to talk with you. There can be a long queue during the week, though, just so you know. If you call during the day, you go to our website, 1-800-928-7496, and you can call our patient support line. And if you get through, great. If you get the service, that means we're working with somebody else. And just know that we will call you back often later in the day or in the evening. Okay. All righty then. Okay. So I'm coming over to Zoom now. And you know what? Let's just go to Annie, since she was the first person to come into the meeting. And guys, you guys with Zoom, don't take it personally if I don't call on you right away. I'm trying to mute and unmute people. And anyway, I do my best. So Annie, how are you? How is life today?
Hi, Jill. How you doing?
I'm good. How are you doing?
Thank you so much. I started watching all your YouTube and Facebook. And I just learned so much. I've had IC for 13 years now, but the last 5 years has been really awful since I had my hysterectomy, because they told me, get a hysterectomy. You have endometriosis so severe. I had to go through IVF to have my daughter.
Okay.
I had the hysterectomy in 2015.
Okay.
And after that, everything just went downhill. And my IC got worse and worse. My pelvic floor muscles got worse and worse. They never told me about topical estrogen cream, which I told my urogynecologist should order for me. So I'm
Okay.
gonna try that.
Good.
You mentioned about the topical estrogen cream.
Okay. Yeah. Yeah.
And then I told her to reorder me some baclofen suppositories for my tight pelvic floor muscles.
Okay.
But she's gonna order that. But the problem is, I have nerve pain now in my legs, arms, around my mouth.
Mm.
It just like central pain sensitization. It's like those five.
Right. Right.
So they sent me to neurologist, and finally they said that they really want me to try trial size of IVIG infusion.
Okay.
So to try to calm down the immune system, so we'll keep attacking itself to calm down the nervous system.
Interesting. Interesting.
I've already tried platelet-rich plasma. I've tried stem cells. I've tried everything.
Well, okay. So the thing that you've got to remember is, let's think about the event that made you worse, which was your hysterectomy.
Yes, that's exactly. Before then, I could still drive. Now I can't drive anymore.
Okay, so when we think, and for for those of you who have never had a hysterectomy, I will tell you it is brutal surgery. Even if they use a non-invasive, a low-invasive robotic approach, the reality is when you take those organs out, it is traumatic, and the recovery is very long.
Yes, it was very long. It was months.
Oh, it was a year for me. I had that. Yeah. It felt like there was a fist up my vagina, because in my case, they took my cervix too. They took everything. I didn't understand why they were taking my cervix, but that's because cancer cells can be, on your cervix also. And the incision point where the cervix was absolutely, and continues to this day, to be incredibly tender. And so it literally felt like there was a fist up my vagina grabbing onto that incision and pulling downwards. Did you ever have that pulling sensation?
Yeah, I had that pulling down sensation.
Right.
And the stitches they took my cervix, my fallopian tubes because of my severe endometriosis.
Right.
They left both ovaries, but the stitches stayed in for months. It wouldn't fall out. Well,
the stitches, they're 90-day stitches anyway. So so you have active stitches for 90 days at a minimum.
But they had to give me morphine. Even morphine didn't help the pain. It was that bad.
Yeah, I totally believe you 100%, because I was there too. Did you ever get your surgical record? I mean, I think that. Okay, and did anything happen during the surgery? Did you have a bleeder? Did they cut something they weren't supposed to cut? I mean, did you ever get a sense that anything funky happened during that procedure? No,
it sounded really normal.
Did they?
I kept asking him for 45 minutes, the surgeon. I said, if this makes my interstitial cystitis worse, I will not do the surgery. I need to know. And I asked him for 45 straight minutes.
Yeah.
It was a Brigham woman in Boston. I said, please just tell me. He said, no, this never happened. Not one person has ever come back to say that the pain got worse. I said, not one person, out of thousands of surgeries. No, not one person. And then I find out from my PT lady, my OBGYN, and my urogynecologist should have told me too. They said they all come back to us. Of course he doesn't know. He's just a surgeon.
Right. Right. And
so I wrote him a letter. I told him that you had a daughter. Would you tell her the truth, or would you just do the surgery for the money? I wrote a long letter.
Yeah.
To him.
Yeah.
He never responded. I said, you changed my life. I'm debilitated because of you now.
Well, so let's think anatomically for a moment. So kind of three things come to mind. The first thing that comes to mind is scar tissue. Do you have scar tissue from that procedure that is compressing a nerve? Is it wrapped around a nerve?
I've been to 6 PT ladies, and I went to one last year finally.
Yeah.
And you're gone. She said, you're so tight down there. So I went, and she gave me back a letter saying that even your vaginal opening is so tender that I feel so bad. You're in so much pain, and until you get better, we can't. After 7 times, we can't do PT anymore because you're worse than when you walk in the door. So I think it's the topical estrogen cream. I'm so dry down here, and then they're
Well,
telling me that I need estrogen topical cream.
Yeah. Well, that's the second thing is that, you know, dryness matters, and the drier you get, the more painful it is. And so you doing something that will help restore some of the integrity of that skin is important. And if the doctor says you can try topical estrogen, that would be a no-brainer to try to see if that can improve the quality and health of your skin.
Okay, I want to go. I want to go back to PT, but it's just so painful that I can't even go back.
But okay, but when you went to physical therapy, was there one part of your pelvis that was hurting the most? Was it in
the left side, just like you said, the left side? I did have an accident years watching all your videos. I did have the accident when I had my daughter 26 years ago on my right side. I broke my pelvis.
Okay, so right, so you are a complex injury patient. You are. And
exactly what you said.
Right. So what we see is that history of recurring trauma, but the fact that you've got nerve pain and pain shooting down your legs, that really points to your piriformis muscle. Is it only on your left side, or is it on your right side now too?
It's on the right side now too. It's way in the back, way in the back where the piriformis muscles are. So because I just had an internal done last, I went to see a New Year gynecologist, and he did platelet-rich plasma. My friend did it, and it helped her 100 lesions, 80% gone. Her bladder was like the gag leg all grew back.
Okay.
But I don't have 100 lesions, so I'm a different kind of person. Well, I didn't know until.
Yeah,
I didn't know.
You're a structural injury patient. You're a structural injury patient.
I paid all this money to do the platelet-rich plasma. I waited 3 months, and it didn't heal my bladder.
I would, but see, but remember, we talked about this. We've got and that's how I started the meeting with the somatovisceral reflex versus the viscerosomatoreflex. So if your bladder wall is changing because fundamentally you've got a problem with muscles and nerves, no bladder therapy is going to fix that. We have to focus on the muscles and nerves. So have you read this book yet?
No, I want to buy, because I like highlighting, like you like circling. Yeah. I'll buy the books through IC Network.
Yeah, buy it. And in fact, I think we have to reorder. But given your previous injury, given the fact that your symptoms are started on one side and then the other, I want you to really read the first 3 chapters, thinking about your trauma and asking yourself, was this affected? Was this affected? Was this affected? I think that this is going to help you substantially to try to understand what could be going on with you. Okay. So I think you're moving in a really, really good direction. Good job.
I learned so much. I like watched 20 of your videos in a row. It was like Jill Osborne, Netflix.
I know, and we're going to do a lot more. I'm going to do a lot more videos the rest of the year, as long as.
How much I learned so much that I think I understand now.
Well, my goal here is I want you to be the squeaky wheel. I don't want patients to be a patient. I don't want you to be a patient. I want you to be active, and I want you to be it's called a respondent, responsible participant, and to keep asking questions. Be a pain in their butt. Did you check this? Did you check this? Did you check this? Can I get this report? I want to see this report. And especially for surgical patients, surgical injury patients, traumatic injury patients, it's important to try to understand what they were dealing with. Now, you said you had it because you had endometriosis, or?
I have severe endometriosis. Right. I had to have my daughter through IVF.
Right. Okay. So there's a chance that the endo is affecting a nerve. True. I mean, we just don't know. So anyway, start with that. Let's see how you do with that. And in the meantime, lots of deep breathing. You gotta listen, girl. You gotta dive into muscle relaxation.
Yes.
Beaumont Hospital. Let me show you. I'm going to share my screen here really quick. Hold on a sec.
Okay.
I want you guys to see this here, but let me I'll get rid of everything else on my screen. All right, share screen. I'm going to my desktop, and you see my owl?
Oh yeah, your owl, yeah.
Isn't that beautiful?
Oh, so pretty.
That's a photographer on Twitter, Simon Wantling from the UK, and he puts these pictures. Okay, so here we go. Front page of our website, right?
Yes.
I want you to go to self-help.
Yep, self-help.
And I want you, whoops, there's a pop-up window. And I want you to go to the third link, guided imagery for IC and relaxation.
Okay.
Okay. These are all the muscle relaxations that were used in research studies, and they proved that patients do better when you learn to take charge of those muscles and get them to relax. And so
I think I have that CD.
Okay, but there's more here. And for everybody here,
more,
these are free. They don't sell the CD.
Yes.
They don't sell the CDs anymore. They're free.
No.
Okay.
Okay.
And for men, they've got 2 for men also, specifically for men with chronic pelvic pain and prostatitis. Hold on, I gotta get a drink of water. Okay. I just like I want to show my website. I like it so much.
Yeah, I looked at it.
New colors. All right, let me get rid of the sharing screen here. All right, here we go. Okay, Annie, you keep in touch.
Okay, well, I'll see you next week. Thank you. God bless you. Thank you for all your help.
You are very, very welcome. And guys, please remember, I'm not a doctor. I'm not giving you medical advice. I'm just trying to give you ideas and trying to help you understand pros and cons and try to understand cause and effect and how this affects that and so forth. My job is to give you the 50% of the info, tell you where the rest can be gotten, and then kick you in the butt and get you back to the doctor, right? In the best possible way. Thank you.
Thank you, Joe. God bless you.
All right. I'm going to go to Dina. Let's see if I can unmute you, Dina, or you can unmute yourself. Or Deanna. Yay, Deanna.
Thank you so much.
How are you doing today?
Not great. It hasn't been a great 30 years, to be honest.
Oh, I'm so sorry. Tell us what's happening today.
Okay, today, well, it's just a constant flare, a 30-year flare.
Okay.
I've never had no symptoms.
Okay.
I've always pain and symptoms.
Okay.
So I've done all the stuff. I've had my hydro distension.
Okay.
Nothing was found. I'm in Texas, and so I went to your website. I went to both doctors. Dr. Bruce is the one that did the hydro distension. Nothing was found. I don't have Hunter lesions.
Okay.
I've tried to put me in a subcategory. They basically don't even acknowledge the subcategories. They keep throwing pain medicine or different things at it. And I'm trying to find my, source. I did the microgen, came back nothing. I don't have fungal. I don't have bacteria.
Okay.
I asked, so then after putting on, he did tramadol, Valium. When I came in for my next check to tell him that none of that even touched me, he sent me to a pain management. I did the legal dose of Texas CBD oil along with another strong pain medicine. Didn't touch it.
Okay.
But back, he wants to insert the TENS unit, I think.
Okay.
Surgical. But I was like, if I want to know the root cause, because if it's not nerve, then that TENS unit's not going to work, correct?
Well, let's before we can have a meaningful conversation about your treatment options, we have to understand your body, right? We need to understand your anatomy. So how old are you now?
50.
And so your symptoms started when you were 20.
Yes.
Okay. Do you associate any event with the onset of your symptoms?
Nothing.
So when you were 20, were you in college?
I was in college, and the year before I had a fallopian tube that got twisted and it was almost gangrene. They had to remove it. And then I had the symptoms a year later.
Okay.
But
So
I've had exploratory surgery. I've had.
Okay, but wait. Just hold on tight. Okay. So it didn't just start out of the blue. You had a major pelvic surgery, a major pelvic surgery a year beforehand. And you had severe pain associated with that condition. Was it a fallopian tube torsion? What'd they call it again?
Yes, they treated me. They thought it was an ovarian cyst. So I was
Okay.
treated for an ovarian cyst for a year, and then finally went into the ER because it was so bad. And then that's when they found my ovaries were fine, but my fallopian tube had gotten twisted and it was so damaged that it was almost gangrene.
Okay. Okay.
So they removed it.
Okay. So, and was it abdominal surgery? Where's your scar?
Like the C-section. So it was like a C-section.
Is it horizontal or vertical? Is it horizontal? Was your scar sensitive?
No, not really.
Okay.
And I was able to have 2 children. I've had the same scar. They went in with the C-section. My symptoms did not go away with pregnancy.
Okay.
I don't match anything.
Okay. No, you do. No, I mean, you do match a surgical patient. You do match patients whose symptoms began after some sort of pelvic trauma or pelvic surgery. So when we think, let me ask you a bunch of questions about your symptoms. Okay. Number one, are your symptoms today the same symptoms that you had 30 years ago?
Yes, ma'am.
Okay. Do you sleep through the night? Only
when I take amitriptyline, melatonin, and the hydroxyzine.
Okay. What wakes you up at night? Urgency, frequency, or pain?
Full bladder feeling, like when you're in the movies and you don't want to move and you have that full bladder.
Okay.
You have to. Yeah.
Okay, and your bladder
don't burn.
Okay, no, that's okay. Let me just I'm just trying to work through this through my head a little bit. So, is it when you get that full bladder? Okay, let me describe a flare, and let me describe the type of flare I had that was a bladder wall flare. So you go to bed at 11. Obviously, you peed before you go to bed. You wake up an hour later, your bladder feels very full. You go to the bathroom, you pee out a quarter of a cup. You go back to bed. You wake up 30 minutes later, your bladder feels very full. You go to the bathroom and you pee out maybe a tablespoon. You go back to bed. If you're lucky, you fall asleep for 15 minutes. You wake up, your bladder feels very full. You go to the bathroom, you sit on the toilet, you strain, and you get a drop, but you feel very, very full. And you're stuck in that fullness for the rest of the night. It's just like, and that's
forever.
Okay. So that's how we know that the bladder wall is severely, severely irritated. It's that false sense of fullness. You feel full even when you're empty.
I've done pelvic floor therapy.
No, hold on. I don't want to hear about treatment. I'm just trying to visualize your anatomy here. That's all. So give me a moment here. Are your symptoms positional? Are they okay?
In the middle only.
Okay, when I mean positional, do they get worse when you sit and do they get better when you stand?
Constant, the same.
Does anything make it worse?
Just when I have to pee more, when the bladder fills up.
Are you diet sensitive? Do foods bother your bladder?
I can't tell because I've never not had symptoms. I've done the diet. I've tried to stick to the diet just because I've been doing all the research, and I know, back in the 80s when I was diagnosed, it was the IC diet, the tomatoes, the chocolate, the alcohol, all of that. So I don't do any of that. Except I'll go a couple of months and then I'll be like, well, it doesn't matter. I'm paying no matter what. So then I might have low acid decaf coffee.
And what happens when you have the low acid decaf coffee?
I might go from a 6 to a 7 in pain level, but it's still at a 9 all the time.
Do you ever feel numbness? Is there any part of your pelvis that's numb? Any of your skin, your vulva, anything at all like that?
No, ma'am.
Do you ever feel a vibration, like you're sitting on a cell phone on vibrate?
A little bit, maybe like a spasm, kind of.
Right?
Yeah.
Okay. It really, God, you know, I don't understand what could have happened in that first surgery. It's almost like they traumatized a nerve. You know, they traumatized your alpha afferent nerve, which would have triggered more frequency urgency. But the question is, I mean, that's where we would try something like a nerve block or Botox. Did you ever have,
Okay, but
did they ever try Botox in your bladder wall?
not yet. I'm on gabapentin because that's my next. I thought if it was nerve related, gabapentin might help. So I've been on that for about 2 or 3 months now.
Okay. Okay. And you noticing any changes?
Nothing.
I think it'd be really interesting to add Peora to the mix because that's known.
I've done that.
So
I've done
are you on it?
bladder builder for 2 months, and then I ran out and I didn't see a significant. I've just been throwing so much money at this.
What about the Peora?
Isn't that the one with bladder builder?
Well, this is just the PEA. They're separate. There's bladder builder versus Peora. This is just a pain fighting ingredient. This is known for kind of calming nerves down. When all the PEA studies have shown that PEA seems to be the most effective at neuropathic driven pain. So, and it also happens to be the cheapest one, which is cool. It's only $24.99 right now. So
I just want to know, you know, like,
are you willing to travel? Are you willing to travel?
Absolutely. Absolutely.
I think you need to go up and see Ken Peters or go out and see Rob Evans. Ken Peters is up at Beaumont Health, up in Royal Oak, Michigan. And they're the top IC research center right now. And then Robert Evans is at Wake Forest in North Carolina. And he is been Doctor of the Year every year we've had the vote. Guys, we haven't announced the 2019 Doctor of the Year because of COVID, so it's really messed everything up. But anyway, your case is complex. You have clearly outpaced the knowledge level of the doctors where you are. And if you like, I would be happy to send them an introduction of your case if you decide that you would like to go see one of them. Because your anatomy is too confusing, and it's almost pointless to talk about therapies until we try to understand what happened 30 years ago that could have caused this. And I'm wondering if, you know, a nerve root was damaged or something. Do you have the original surgical report from the original surgery?
I don't even know if he's in practice anymore, but I could try to find it.
Well, it's an interesting case. And you know what? If you email me, icnetwork@mac.com, I send letters out to our board, our medical. I just sent one out yesterday on behalf of a doctor with IC. I like to send them interesting cases. And your case is very unusual. It's very.
I did email you a while back, but I know you get so much.
I do. So when you when you guys send me email, capital letters. Do the subject in capital letters. Say important. Read this, because I do get at least 100 emails a day. I say so. I talk to you, and just say symptoms began after surgery.
Okay.
And I mean, I think it would be really interesting to try to visualize the pelvis a little bit, the pelvic cavity a little bit more, just out of curiosity. I mean, you're a mystery. I think any doctor is going to want to do that. Like, have you had an MRI of your pelvis or a CAT?
I had the CAT scan.
Okay.
And said nothing.
Well, that's what they say, but they may not know. Where if you're working with one of the top tier doctors, they may have seen a case like yours before. So what we do know is that history of pelvic surgery is a strong risk factor for pelvic pain. And so you're checking all those boxes. No, the anatomy just doesn't quite make sense to me. you know, and I'm so sorry that this has happened to you. And listen, girl, you are an incredibly strong woman because you've made it through 30 years with this.
Strong.
But
Thank you. I don't feel strong.
you have never been stronger than you have ever been than you are at this very moment, because you are truly one day older and one day wiser. You will, and you know, respect and honor your strength. You are you're a hero. You are your own hero, but you are a hero to the IC movement, because what your inquiries are going to do is they're going to help other people too. And I will help you. If you call me, I will write out a case history for you, and then I will see what I can do to pass it along, see if I can get some additional insight. I got really good connections. And let's see if we can find anything. I will try to research this for you. I promise you I will. Okay.
Thank you so much.
Oh, girl, honey, I want you to feel my arms right now. They are right behind you right now. And we're going to try to figure this out and get you to doctors who will do a better job figuring out. There's another doctor, Robert Eckenberg, outside of Philly, who is the nation's pelvic pain doctor. He would be very interesting. But I guess what's coming to mind are diagnostic nerve blocks. It would be very interesting to see if a nerve block turned off that constant urgency fullness for you. That would be really fascinating. Botox might be interesting. It's again, I'm not a doctor. I can't give you medical advice. That's just kind of intuitively kind of where my head is going. And anytime it happens after some sort of physical trauma, it's like we want to know what that trauma was, you know? You were 20. Is your mom still with you?
No, ma'am.
Do you have sisters? Or
I have one.
Was she around when you had that surgery?
She's younger, so no.
Okay. Well, listen, let's talk this week. We're going to put our heads together. We're going to write it up. We'll see if we can find some answers for you, okay? And I will look for some other groups, and maybe I'll reach out to Dr. Eckenberg on your behalf and see if he has experienced anything like this before. We'll see what we can do, okay?
I will go wherever. So wherever you recommend, whatever doctor, if you want to take time to think about it, or if you have more questions.
Well, guys, you know, there's like 5 doctors in the country that are the top tier IC doctors. And you know, I talk on our website. You got local, regional, national doctors. It's not unusual for IC patients to completely defeat the education level of the local doctor. They just don't see enough. And you've already been to your regional doctors, and your case is already too complex for your regional doctors. They haven't helped you in 30 years. So you have to be at that national level now. And I can't think of anybody better than Ken Peters, Rob Evans, Rob Moldwin, you know, in that part of the country. And I think or Robert Eckenberg in that part of the country. So don't you dare give up. Don't you dare give up. Let's see what we can do to figure this out, okay?
Thank you so much. You
are very, very welcome. Very, very welcome. Okay, now see, I'm going to be thinking about you for the next 24 hours. And because I want to, your case is so important for other patients to understand and other clinicians to, you'd be a great case study. You'd be a great case study, you know? So let's see what we can do. Okay, I'm going to mute you, and oh, you muted yourself. Thank you very much. Let's check in with Lisa. Yeah, you. Yeah, you. Lisa, can you unmute yourself?
Did it.
Girl, how are you today?
So I just want to ask Deanna where in Texas she is, because I'm in Texas as well. Can you unmute her for just a minute?
Yeah. Hold on. Deanna, you can unmute yourself too. All right. So Deanna, Lisa is also from Texas. Where are you in Texas?
I'm in the Austin area.
Okay. I get up there quite often because my brother actually, well, not lately, but my brother and his family lives up there. So, but I was going to say, as far as I know, there are no good IC doctors in Texas.
No.
And it's amazing because we have an amazing medical center here in Houston. And, you know, I've struggled and struggled and struggled and gone from urologist to urogynecologist to gynecologist to, you know, and there was just no one.
Well, you got Chris Smith at Baylor.
Yeah, but yeah, Chris is pretty much a Botox guy.
Right. Yeah.
And I know Chris, and he's a good guy, and he does research. He's one of the few that are actually dedicated to doing IC research.
Right.
But he really is pretty much a Botox guy. Have you tried Botox, Deanna?
No.
If you do go that route, then that's who I would recommend
Yeah.
you see. It's Chris Smith at Baylor in Houston.
Yeah.
He is excellent. I just was talking to a friend of mine yesterday who just had Botox a couple days ago, and she gets it on a regular basis, and it's about the only thing that helps her. So
yeah. So
is it painful?
huh?
Is it painful?
It's not painful. They put you under. I mean, I think you're uncomfortable for a day or two, but it really helps with all of her symptoms.
So
and she has not only IC, but she also has lymphedema and a bunch of other health issues.
Yeah. So Botox by itself is not painful because it actually silences nerves. So the nerve is deadened for a period of time. It can be deadened for a couple of weeks, couple of months. And the Botox can be put in two places. It can be put in the bladder wall, or it can be put in the pelvic floor. If they put it in the bladder wall, there is a risk of you not being able to urinate afterwards if it accidentally silences that nerve. But if it's put in the pelvic floor, it's not the same circumstance. And it's too early right now to say that Botox would work for you. You still have to have a proper anatomical workup by one of the experts, Deanna, first, to just try to understand your pelvic cavity a little bit more, okay?
But and with the non-essential, you know, even in Houston, you can't do any non-essential procedures anymore. My friend just got in right under the cutoff here, but I will say that I went from doctor to doctor in Houston, and my GP recommended I go see this one doctor at Methodist. Methodist is a great hospital system, and she was honest, and she looked at me and she said, you know, and I did make the mistake of going in and saying I have IC. So I immediately fell down the IC rabbit hole. And she said, you know, urologists hate to have IC patients come in. She was very honest. She said, urologists hate to have IC patients come in because there's nothing we can do to help you. Well, okay, thank you. So she said to me, what do you want me to do for you? She's asking me. And I'm there sitting and thinking, I'm the patient, you're the doctor. So I said, well, like a cystoscopy, you know, maybe God, my brain's not even working today. I've been by myself for so long, I can't even think anymore. What is it called when you get the rescue installation?
Oh, okay.
I said, what about a rescue installation? So she did that. And then I heard the nurse say when she was setting up, what about Lisa White? And she said, oh, you don't need to worry about scheduling her cystoscopy because this isn't urgent.
Yeah.
I overheard that and I thought, not urgent. I'm suffering, not urgent. So that is kind of what we get. But
okay.
I'm in Houston, so.
Okay,
yeah.
so guys, just to kind of fill in, Lisa has been dealing with a very weird bowel infection / disorder, right?
It's not an infection, but yeah.
Okay, I'm sorry. What's the name of it?
Microscopic colitis.
Microscopic microscopic colitis. Why is it using the microscope? Why is it saying microscopic?
It's called that because, like with ulcerative colitis, which is what most people have heard of.
Yeah.
If you have a colonoscopy and you go in, you can actually see it. On the colon walls, you can see the ulcers.
Okay.
But with microscopic colitis, when you do a colonoscopy, you go in and the colon looks fine. It looks normal. So you have to do a biopsy and look at it under the microscope.
So that's why. Okay. That's why they call it microscope. How is your IC today? Are you doing okay?
You know, I am like so blessed because my IC has been okay. I mean, I pee more than a normal person, but and I still take some pain meds.
Okay.
And some Valium and gabapentin.
Yeah.
I take gabapentin.
Yeah.
But it's very tolerable right now. But just to, you know, what I appreciate is coming on here and listening to people's stories, because like I was so sick about 2 years ago, maybe, that I couldn't take care of myself anymore. I could not do it. And I had to have somebody move in with me and be a caregiver for me. I couldn't shop and cook for myself. And I have a 3rd floor. He moved up there, and it worked out good for me because he took care of me, and it worked out good for him financially. So, but I was so weak and so sick and on so much pain med that he had to serve me my food on the couch. And so you can get better. I mean, Deanna, I didn't suffer for 30 years, but you know, I suffered and then I got better for a long time and then I came back. And so, you know, you do everything you can possibly think of. I mean, I talk to Jill a lot. I did a lot of private coaching. And I did, you know, I did pelvic floor physical therapy. I did PTNS, which is you know what that is, Jill.
Yeah.
And I just gradually, my symptoms got better and I got better and stronger. And in December, I started being able to get up and cook for myself. And, you know, it worked out well because by March, I was cooking for myself. And I told my roommate that I wanted him to move out because he was a tennis coach.
Yeah.
And I had decided not to go to the gym because of COVID.
Yeah.
And to me, it was like, what good does it do me to not go to the gym if he's going to be at the gym all day teaching tennis and then coming home? So he moved out in the middle of March. So, but I feel very blessed. But, you know, I'm a big fan of Jill Osborne. So
thank you. Thank
and
you.
I'm very, very sorry for all you guys who are suffering, but don't give up because because you can get better. And I'm really jealous of Mary Brinkman sitting down there outside.
Okay, hon, I'm gonna.
I also want to know how you put your picture up there instead of having you. Like maybe when she comes on, she can tell us how she puts her picture up.
Okay, and you're talking about. Okay. All right, I'm going to mute you, Lisa. Nice talking with you. Okay. All right. Brad. Hello, Brad. How are you doing today?
Well, it's not Brad. My name is Deb. I'm on my husband's computer.
Oh. Well, hello, Deb.
I'm from Ontario, Canada.
Okay.
And I've been listening to you, Jill, for quite some time now, and thank you. You have been very informative and educational.
Thank you.
My blessings to those other gals we were just speaking to. I'm nowhere's at that, or I haven't been in years, so I feel almost a bit guilty here. All I'm dealing with right now is frequency. I mean, urgency is there sometimes. Pain is almost gone, although I have a bowel bladder back and forth that I don't know where the pain's coming from.
Yeah.
I wanted you to know that the Elmiron issue has finally made national news here in Canada. And urologists here in Canada are finally starting to see that there's issues with Elmiron. I am an Elmiron patient. I'm gradually dropping what I'm taking, and I probably will go off of it very soon because it does make me a little nervous.
Yeah.
I don't think it's doing anything anymore. I think it did help. My urologist has said there was damage to the bladder wall, and he uses the word ulcers.
Okay.
And I'm assuming that's lesions, but that's an assumption, and I know I shouldn't do that.
Were you a patient of Curtis Nichols?
No. Is he Kingston?
Is he what?
Is he over at Queen's University?
Yes.
No, I'm near London. My urogynecologist is here.
Okay.
And I quite like him. We have good discussions and whatnot. I have read on your website about Curtis. Might be someone I would like to go see at some point. I'm looking for sleep. I would love to get an evening's sleep back in.
Well, so as you know, Canada healthcare is really about 20 years behind everybody else, to be quite honest. It's baffling why it's as uneducated as it is. I don't, Curtis Nichols is literally one of the top researchers in the world. He's a brilliant writer. He's a brilliant author. He created part of the U-Point system, which is a diagnostic system used in the new Canadian IC guidelines. If you didn't know, right. Canada did create finally their own IC guidelines using the U-Point subtyping phenotyping system. And yet, despite that, I'm not aware of a single class taught on IC in any of the Canada meetings, at least that I've seen. Granted, I don't look at all of them, but generally what happens is that you'll be diagnosed with IC, they'll throw cystostat at you or Uracyst at you or Elmiron at you, and then they're done with you. If you're able to get a pelvic floor assessment, then that's wonderful because that doesn't happen to a lot of people. Most patients in Ontario go down and see Ken Peters at Beaumont because he's just right over the lake. I mean, it's 45 minutes away.
Is that Royal Oak?
Yeah.
Yeah, it's just a stone's throw away.
Right.
I have done pelvic floor, and I must admit, and I think that's some of my concern. Pelvic floor, I did the best. A naturopath directed me to pelvic floor.
Okay.
And I did really well until my therapist decided to move. And I spoke to her about that.
Right.
But understandably, so I found a second one. Now I'm just struggling finding a physiotherapist that I have a relationship with.
So there's a new website called pelvicguru.com, and it's a master list of physical therapists doing pelvic floor therapy around the world. So check pelvicguru.com.
Right.
And then on our website,
search in my community or in my region, and there are a number of them.
Yeah.
They're just not all as good as the other ones.
Right.
Right. And I had a good relationship with one. I just want her to move back. That's all.
Well, the cool thing is though, but see, hon, the cool thing is that you did it and it helped.
Yes.
And so that really gives us a clue that your dominant issue is probably your pelvic floor. And hopefully she gave you home exercises that you can do.
Yes, she did.
And are you doing them?
Sometimes.
You might be just a wee bit passive aggressive, like I can be sometimes.
I cannot tell a lie.
Are you using a wand?
No, I am not.
Well,
that's I know that's the next step I need to do.
Yeah, you should have been doing this from day one. A wand like this. It's very hard to use a wand at first because you're just really not sure what you're touching and how to do it. And it really takes a book like this to help you visualize and understand what you're touching.
Exactly.
This is such a good book. And the fact
you said that Dr. Weiss is now retired?
Yeah, he's 81 now and he's in poor health.
Is there anyone taking on that work?
His patients have been referred to Dr. Dr. Jeanette Potts, at Vista Urology in San Jose, but there's no reason for you to fly out here. You've got Ken Peters has a state-of-the-art women's health clinic with physical therapists on staff who are trained like, the best in the world. So
we're still dealing with a closed border though. So
that's true. Well,
I'm nowhere near that discomfort. I mean, I can wait. So,
and that's why you, if anybody, needs to absorb this book and just get it on Kindle. Just get you. Don't wait for. Don't have us send it to you. It's be too expensive and too slow. It's free. It's free on Kindle Unlimited. It's $9.99 for regular Kindle. That book will help you understand why that physical therapy was helping you.
Well, and in the description you give of that book, and also in the midst of this, I've been diagnosed 5 years now. And in the midst of this, I've had a hip replacement and now issues with an ankle and a knee. So I think it's all little lights are going on. It's all connected.
Well, exactly. The chapter in here on the feet are going to blow your mind. It's like, oh, this whole chapter, the sacrum and the feet. And the pictures in here, there are pictures in here of what they're touching. I mean, I don't really want to show, but it will help you kind of visualize what your physical therapist might have been doing.
Exactly.
But, this chapter is going to be a chapter I think that you're going to find very, very meaningful. So that's what I think you need to do is get the book, read it, and start thinking about your history, thinking about your symptoms, thinking about what that physical therapist was doing, what was she touching, and now understanding the impact of your foot and your knee on your pelvic floor. And you may be, if we go back in time to when your symptoms began, you might not be a bladder wall patient. You might just be a pelvic floor patient.
And that's exactly what I'm thinking now.
I think so too. Yeah. Perfect. So, okay.
Great.
Well, keep in touch. Let me know. All right.
Thank you.
All right. Fern. Okay. I got lots of people waiting. Okay. Mary's waving. So I've got Mary and I've got Fern. You guys are the last two, right? Mary, do you have a time issue? Are you okay time-wise? Okay, then I'm going to come to Fern. So give me a moment here. And you guys, now for those of you stuck around, you guys are going to get the giveaway. So anybody watching on YouTube and Facebook, our giveaway is going to be this. New Dawn Pilates for pelvic pain. All right. And even though the security seal is it's just been sitting on my shelf, so it's still okay. Let me look at it real quick. Okay. All right. So Fern, I'm going to unmute you. And so you guys, we still have people on Facebook and YouTube watching. So on Facebook, Marion said, do I know of a good IC specialist in Ireland? I do not. Marion, what you need to do is you need to contact the Bladder Health UK group. And they're the ones who maintain the list of doctors in the UK. All right. And so if anybody's going to be able to help, it's going to be that group. Although I would be happy offline to try to help you. Gail, any recommendations for Augusta, Georgia? Denise Pecht, P-E-C-H-T. I don't know how far she is from Augusta, but she's who we're sending people to in Georgia. Denise Pecht. P as in Paul, E, C as in Charlie, H as in Harry, T as in Tom. Mary says, can I consider captions? My hearing is a bit off. I don't know how to turn them on. If I were using streaming software, I might be able to do that. The problem is we're simulcasting 3 ways right now. YouTube, Facebook, and Zoom. But when you watch the video on YouTube, you can turn captions on. All right, so Fern. I'm trying to unmute you. Can you unmute yourself, Fern? I can't hear you. We got to unmute you.
Okay.
There you go.
Okay, Tom, come down.
All right. How are you, my friend?
Okay.
I know we've talked on the phone. We either talked on the phone a couple of times and by email.
Yes, we did. Not email because I never had it, but
Okay.
we did talk on the phone.
Okay.
So, and you are so wonderful. I love you so much. I wish I could hug and kiss you. So this all started, I'm 70 years old.
Okay.
And this all started about a month ago.
Okay.
I have post-infectious colitis with constipation. I don't think we talked about that when I talked to you on the phone.
Okay.
I had a very bad E. coli infection from contaminated seafood a year ago in May, and the nerve cells in my bowels never regenerated.
Okay.
So it's led to constipation. I have to take Miralax every day to poop.
Okay.
I also have, as you saw on there, angioedema. For the past 40, 50 years, I've had so many recurrent UTIs and was treated with so many antibiotics. They were saying that I had allergies, and finally now they're telling me it's angioedema. So
where is your edema? In your legs, in your ankles?
The angioedema, it starts, both my hands start to itch, my lips swell, my eyes swell, and if I don't get to the emergency room in time, I'll get the hives in my throat.
Okay. And what causes that? What triggers that?
They're calling it idiopathic right now.
Really?
I've just seen a doctor at University of Pennsylvania, and he's done a lot of lab work on me. My tryptase level is only 4.7. It's not high enough to say mast cell activation syndrome.
Okay.
All right. So about a month ago, I guess I pushed too hard, and I pushed out part of my bladder and pushed out part of my urethra.
Okay.
So the doctor said, oh, you need to do Kegels. So, and we discussed this. I did the Kegels, and I was so diligent with them that night I started with the symptoms of IC, the burning, the pressure, the pain,
right,
the spasms. Okay.
Right.
I saw a doctor down at Cooper, and matter of factly, she said to me, you have IC. I didn't even know what it was, Jill. She gave me a prescription for Urabel.
And when was that? Wait. When was this?
June the 10th.
I mean, a diagnosis of IC should not be made in the first 6 weeks. She made your diagnosis of IC in 10 days?
She did it based on my symptoms, and I had 3 negative urine CNSs.
Okay.
But she did say to me that somewhere down the road, she's going to have to do a cystoscopy to look.
Okay.
And Wednesday of this week, I have my first pelvic floor evaluation.
Good.
But I'm so miserable that I had to go back and see her again last week. And she was very curt with me. And she told me, as I said on the site before, that I need to get a handle on things. I need to recognize that I have a problem. And I need to see a psychiatrist.
Oh.
Now, I saw another doctor last week that's a urogynecologist that was written up in New Jersey Magazine as far as the best doctors, and he was an absolute atrocity. I'm not even going to go into that.
Okay.
He decided to do a cath urine, never told me he was going to do it, and then I was terrified I was going to get a UTI.
Right.
All right, so my things are, I'm trying to find somebody else to go to. Tomorrow we're going to a Dr. Carabello, who is all the way up in Summit, New Jersey. I don't know if you've ever heard of him.
No.
I did get all the doctors off of your website too, and I have no problem traveling any place. But
So Fern, let me just say a couple of things here. You are in no way a typical IC patient. In no way. But what makes your case very interesting is that you do have a history of recurring UTIs that go back decades, right?
Right.
So sometimes we see patients who think that they have E. coli for years and years and years and years and years, only to discover after the fact that their cultures were actually negative. In fact, there was a research study that was done of IC patients who had taken antibiotics for about 10 years. And when they went back and they looked at their urine results, only one out of, I don't remember how many were in the study, either 50 or 100, only one actually had ever had a positive UTI. The rest actually had inconclusive urine reports. So if we go back in time, and when you say you had all these recurring infections, did the lab results support infection?
Yes.
And was it always E. coli?
Most of the time, yeah. Most of the time.
So,
see, the other
okay,
thing
wait. So,
okay.
When did those start?
They actually started in my 30s.
Okay.
I was trying to get pregnant with my son, and I probably didn't get up and go to the bathroom after I should have, and got one infection after another. So a couple of the things they did, sulfa was the first drug. I didn't even put that on there.
Okay, wait. Okay, so wait. I don't want to hear about the treatments yet. I'm just trying to understand your anatomy, right? That's what we have to do. We got to try to understand your anatomy.
Sure.
When we think about recurring infections, somebody did. David just on Facebook says, I see Dr. Lee in Vineland, New Jersey. He's pretty good. He's a urologist. So David on Facebook. Hi, David, by the way. David just suggested Dr. Lee in Vineland, New Jersey.
Okay. Thank you, David.
So when we think about recurring UTIs, we're really thinking about, number one, is there a source in your daily life that is just constantly inoculating you? So just let me go through this. So the number one suspect would be a hot tub or a bathtub with jets in it, where the jets have been installed incorrectly and they're pointing upwards and water collects and it becomes a perfect bacteria farm. So concept number one is, was there something in your daily life that was constantly infecting you? Concept number two is, could there be a little tiny fistula or connection between the vagina and the bowel? That happens. That does happen, where there's a little tube that is causing cross connection from the bowel to the urethra or to the vagina or to the bladder, usually to the vagina or somewhere in that area. Is there something structural? Like one of the patients that I know that I've been very, very good friends with over the years, she suddenly became incontinent. And when she went they did the surgery for the incontinence, they found out she had a birth defect down there. She had a birth defect where her perineum was abnormally long that caused some issues. And so we're trying to think structurally, is there something that would make you more prone to that? Then the third thing is the fact that despite the hype that says that women with recurring infections are dirty and not hygienic, and how many times can we all get the lecture on wiping from front to back? We now know that a lot of E. coli infections come from food, and you are already proof of that because you got a bad E. coli infection from seafood. Right. And so we also know that hormones matter, that if your skin is dry, you're going to be more vulnerable to infection. And so going back to when you were 30, was there anything going on with your periods?
No, not really.
Okay.
And Jill, let me just tell you, I haven't had a UTI in about 2 years now.
Okay.
I did have a procedure done, urethral cystoplasty, I think, where they stretched the urethra because the doctor said I had so much scar tissue in there that if somebody ever had to insert a catheter, he would never get in. So that has helped me a lot. The last one I had was probably my own fault, my own stupidity. I sat around in a wet bathing suit too long.
Yeah. We've all done that.
I didn't even know that could cause that.
Well, don't beat yourself up. There, it's kind of like lessons learned. I think the important point here is according to the National Institutes of Health, a diagnosis of, and the American Urology Association, a diagnosis of IC cannot be made unless that patient has 6 weeks of pain. And so I do think it's a little premature to give you a diagnosis of IC right now, although obviously your doctor is absolutely entitled to their opinion and your symptoms are suggestive of it. But you still haven't had a total diagnostic workup. And I think it'd be really interesting to have a next generation urine test just to see if there's anything funky going on with bacteria or fungi in your candida in your urine. I think that would be, in my opinion, given the fact that you had the infectious colitis, I think it would be absolutely fascinating to do a next generation urine test to see what's living in your urine. You know, that to me is interesting, because could this be a fungal infection from antibiotic use because of the antibiotics you were taking because of the colitis? Maybe. That's a possibility. Yeah. The other thing that it could be is that you might have just hit that point of estrogen atrophy where your bladder wall is just more vulnerable.
Right. That's one thing that had helped me all those years. And right now they have me on a one that was compounded.
Yeah.
So that because she thought that I might be having an allergic reaction to the cream, and I was on that for years.
I mean, what makes you hard is your idiopathic angioedema, and that's
and that's why I'm worried about when she wants to do a cystoscope, but I'm really worried because what are they going to put me on for prophylaxis?
Yeah, well, you're going to have a talk with her, and I again, even before you do that, I think the next generation test would be very revealing. You know, I mean, before you go for an invasive, I mean, what do they say with testing, right? That we want to do the easy stuff before we do the invasive stuff. So the next generation test is easy. You just pee in a cup, right?
She wants me to go back to my UPenn doctor and have desensitization done to ANSAP before she does it.
Well, I don't know anything about that. If she says that will help, I mean, she's your doctor, she's your expert. You got to do that. But you're not a typical IC patient. You're not. I mean, you would be a typical estrogen atrophy patient just because of your age. But the whole post-infectious colitis, you know, is interesting. And in a way, you're kind of like Lisa, where Lisa also was dealing with a microscopic colitis. Right? Except Lisa's was not infectious, where yours was infectious. I would also be it would be very interesting to talk with a infectious disease specialist about the type of E. coli you had and the systemic effects that could happen with that type of infection.
I had enteropathogenic, enterotoxigenic, and enteroaggrative. I got hit with a triple whammy.
Yeah. Yeah, girl, you got hit hard. You got hit very, very hard. So fundamentally, a priority has to be to try to strengthen your skin. And unfortunately, that, you know, that would be concept number one, is just make sure your skin is as healthy as it can be. But the other thing that might be reasonable would be, I mean, I'm dealing with this with a family member who was just getting infection, bladder infection after bladder infection after bladder infection, and had been for years. And they've just discovered that her IgG levels are stunningly low. And that and she was having kind of liver pain, stuff like that, bowel pain, liver pain, food-driven pain, couldn't eat any fats. And they took her gallbladder out because they thought it was her gallbladder, but 6 weeks after they removed her gallbladder, all the liver pain was back. And anyway, to make a very long story short, what it's come down to is it's like an autoimmune issue with her IgG levels. And what they said is that it's not, it could be genetic. It could be related to another autoimmune disorder like Sjogren's syndrome or something like that. But she has.
I do have a positive ANA, but it's very low.
Okay.
Low.
But
like a 1 to 8.
It might be, it might be interesting to talk about autoimmunity and to see where your immunoglobulin levels are.
Okay.
It might be interesting. I don't know.
I have another visit with the new pen doctor in a couple of weeks to talk about the desensitization. But prior to that, there was a whole bunch of other lab work that I had done, other histamine levels and urine levels and a whole lot of other stuff to rule out. And I don't even have those results yet.
Okay,
but
well,
I do want to tell you is this. The psychiatrist that I did see prescribed Elavil.
Okay.
Is that right? Elavil?
Okay.
Yeah. And told me to take it at night, start with 10 milligrams, take it at night, wait a couple of days, see if I got any relief. The doctor that I saw down at Cooper won't do anything with me, anything further than the Urabel. And the Urabel only gave me relief for 1 day. 1 day. I don't know why it stopped working. I even called the pharmaceutical company in California. They don't understand. They said I might be a high metabolizer. But the only thing that gives me a little bit of relief is I take the Urabel and the Pyridium. I'm watching my diet. The doctor down in Cooper said she won't do anything more for me until I get the pelvic floor assessment, which is going to be this week.
Right. So
maybe I brought it on myself by doing all those diligent Kegels.
No, well, we don't know. Listen, don't agonize. Don't blame yourself. Something happened. It's not your fault. There's no shame. There's no blame. Please don't beat yourself up about this. For all of us, we did things we didn't know. We just didn't know about. And so I don't want you to carry that heavy burden of feeling guilty or feeling like this is your fault. Listen.
But why I'm not a typical IC patient, Joe?
Well, because people aren't normally diagnosed with IC after 2 weeks. People are normally diagnosed with IC after a couple of months of long-term chronic issues. You are a pelvic pain patient. Yeah. But are you an IC patient? I don't know. And there are lots of things you haven't ruled out yet. You could have, you've got the histamine test coming up. You've got the pelvic floor exam coming up. So why don't you just kind of slow down, take a deep breath, work through it very methodically, and let's see what those other things find. Okay? And just
Wednesday, and I'll see what happens tomorrow.
Yeah.
And I'll be in touch. I want to connect with you and probably do a private consult.
Okay.
Whatever. Yeah.
Okay. Okay, but let's wait. We want to wait until you get more results.
The last thing I want to tell you is my urologist did do a CT scan on me.
Okay.
Just to rule out stones, and he told me just the other day that my bladder looks very healthy.
Good. That's great news.
So he said, so if this is IC, you are very early.
Absolutely. It just doesn't sound like typical IC. You got good news here. Your bladder wall looks great. You look healthy. You got a history of infection that's very, very interesting and unusual. You got a wicked, the worst of the worst E. coli infection from food a year ago.
Yeah.
And how long were you on antibiotics for that?
She gave me a Z-Pak and I think 5 days, and then the repeat PCR was negative.
Okay.
So it was only 5 days.
Okay. I think
But the nerve cells just never regenerate.
Well, I still really like the idea of doing a next generation test just out of curiosity more than anything else, just to see if it maybe, I mean, I just don't know. To me, that's just anytime infection comes up, it's like, let's see what the next generation test finds, especially with respect to antibiotic resistance genes or anything at all like that. You know, it's interesting.
Okay.
Yeah. Okay, hon. But lots of deep breathing. And I don't want you believing that this is all in your head. It absolutely is not all in your head. Those infections that you had for many years were not all in your head. And so don't beat yourself up, and don't let anybody else beat you up about this. Okay.
So one last thing. My urologist said to try my Betric rather than Ditrovan.
Yeah.
And the psychiatrist just gave me Elavil. Now I haven't tried any of them yet. There's, because both the Mybetriq and the Ditrovan, right on the product information, can cause angioedema. So I don't know. I think the first thing I'm going to try is the Elavil.
Why don't you just wait? Maybe, okay. I mean, have a consult with your doctor, express your concerns about the angioedema, and let's see if we can just wait for those, a little bit more testing.
All right.
Okay. And let's just, you're like, it's, at this point in time, we look for layers, and you've only taken off the top layer, and there's probably 6 or 7 layers underneath it that we got to try to figure out. We got to figure out the estrogen. We got to figure out the mesels. Got to figure out if there's any other type of infectious thing going on, and so forth. Okay.
And who is this doctor you recommended in Philly? Because I'm in New Jersey. I didn't see him on the website.
Robert Eckenberg. Eckenberg. E is in Eric, C is in Charlie, H is in Harry, E is in Eric, N is in Nancy, B is in Bob, E is in Eric, R is in Robert, G is in George. Eckenberg. Okay?
Okay.
All right, hon. Okay, we'll talk again. Carry,
all right, honey. Thank you.
Carry hope in your heart. All right. Mary. Okay, now your voice is very, very faint.
Okay.
Can you speak up a little bit? Or put the mic closer to you?
Yeah, let me do it like this. Is this better?
A little bit.
Okay. Let me take it off the speaker.
Let's see here, Mary.
I've got it on a speaker, so can you hear me now?
That's better. Just try to speak up and get close to your computer.
Okay. All right. Well, first of all, sorry, I'm in my pool.
Oh, nice. Okay, we will.
I didn't mean to get on. I mean, I didn't think I could get on, and I heard you talk, and I thought, wait a minute, maybe I can. So anyway, so let me tell you my little puzzle pieces.
Okay.
And I've learned a lot just listening. Okay. I'm 57 years old. I had 2 pregnancies, both normal pregnancies, but very big babies, 9 to 10 pound babies.
Okay.
All right. Then about age 40, I did a sling because I was leaking, and I thought I'm too young to be leaking. I didn't want to be like my mom. Yes.
So was it a mesh? Was it a mesh?
I think it was a sling.
Okay.
Okay. Then then things were great, no problem, anything good. Then about 10 years ago, I had real severe abdominal pain. And after doing all kinds of stuff, they finally went in through my navel and the scope, and I had abdominal adhesions that went from all the way across the top of my my bladder, my fallopian tubes, my uterus, all that. So
okay.
He removed all of those.
Okay.
So
Wait. What did he think those adhesions were from?
Well, I asked him, and he thought maybe the pregnancies.
Okay.
Because I didn't have any injuries or anything like that.
Okay.
So that's what he thought they were from. But just the picture he showed me after surgery was just these white, like a spider web going across my pelvic area.
Fascinating.
So then, yeah. So then, I've been since then, I guess it's just been a gradual thing. You don't really understand when it all came, but getting up in the middle of the night, going to the bathroom every 1 hour, 2 hours.
Okay.
The doctor said, you don't need to be doing that. So we put the overactive bladder medicine. Okay, try that. And so I went back after a year and said, well, it's not really helping. He said, well, just adjust the medicine, take it, different times, watch when you finish your drinking at the end of the day. Well, then I told him it's described, and somebody else described it, like when you go, when you use the bathroom, your bladder feels full, like she's talking about the movie theater,
Mm-hmm.
and then you go urinate, and then it still feels full.
Right.
So those are, that's the pressure. Okay, about in March, I started, I haven't had a period in 4 or 5 years, but in March, I started spotting. And then about just 4 or 5, times. So, and then about the same time, well, anyway, about 2 weeks ago, I started having a flare because I didn't know anything about all this stuff then. But just constant pressure pain. So I thought I had maybe a bladder infection. I've never had, I'm not prone to those. I don't have those. So, but I just thought maybe that's what it was. So went in, did a culture. Everything was okay. He did an ultrasound. My ovaries look good. Everything looks good in my uterus. So all that's good. He sent me to the urologist, and I went about June 17th. And they did the first kind of a PA nurse, whatever, did just the first exam. Put me on the my whatever this is. Yeah. Okay. For 2 weeks, and to do the elimination diet. And I'm going back on Wednesday for the pelvic. Okay. So I haven't had a lot of, the pressure is eased up.
Okay.
But it's not gone all the way. So one question is, could my spotting, my hormone change be with my bladder? Because you talked about the estrogen. He had told me to increase this Provarian.
Okay.
I was going to take a tablet. Can we take 1 tablet?
Okay.
Estrogen tablet. Okay, so those are my things there. And so I'm on the elimination diet. I've been really very strict on that. And so my question, I guess, is going back. She also have set up, they've got me scheduled for a physical therapy. So
Okay.
that's scheduled.
And so
but I don't know.
So he found that your muscles were tight, and that's why he sent you to PT.
No, he hasn't done that yet. That's what he's going to do Wednesday. But
Okay.
They went ahead and scheduled that just in case that might be what it is. So my question is, when I go back for the exam, the pelvic exam,
Mm-hmm.
and what else? Is there anything else I should ask him to do, like scope it to see if there's lesions? Is there anything else?
Well, I think so. I wasn't following as long. Let me ask you some questions because I wasn't following along as well. So let me just kind of come back through this for a moment. How old are you now?
57.
57. And this most recent event began a month ago.
About a month. Yeah.
Were you spotting urine, or were you spotting blood from your vagina? Uh-oh. Her screen froze. No! Mary. Uh-oh. Is she moving for anybody else? No, she froze. Oh, I don't know if she can hear me. Mary? Mary, I don't know if you can hear me or not. Mary, log out and log back in. I think I can hear some. Okay, we lost you, hon. Try to log out and log back in.
I don't know.
Okay, I heard you say, I don't know. Your screen is totally frozen. So, okay, so I think you can hear me. So normally a woman, and you're, okay, so your picture just changed.
I'm sorry, Jill. I don't know.
Okay, I can hear you.
I don't know what to do.
Okay, you can just turn your camera off and on. Try to turn your camera off and on. I'm seeing you playing with the volume. Try turning your camera off and on. Okay. Can you, yeah. Mary says you are frozen. Mary, I think it's your connection. So I tell you what, Mary, why don't you call me tomorrow and let's talk, okay? Actually, call me on Tuesday. I usually take Mondays off. Call me on Tuesday and let's talk.
I'm still here. I'm just checking.
Okay, so normally in a woman of your age who starts developing these symptoms fairly menopause, genitourinary syndrome of menopause, estrogen atrophy, and that's what I think you need to do before your appointment is you need to Google estrogen atrophy, but more importantly, genitourinary syndrome of menopause, and take a look at the other symptoms and see if that fits you, okay? Because that's not a disease process. That is just the loss of estrogen. So if your vulva is dry and your vagina is dry, then so is your urethra and so is your bladder. And that could explain why your bladder has now become more vulnerable to certain foods and stuff. Make sense? Okay, yeah. Okay, so call me on Tuesday. Just go to our website, get the phone number, and call me on Tuesday, and we can talk. Okay? Because your connection has gone to heck, and now all we hear is static. So I'm going to go ahead and mute you. All right. So who have we? We've got Lailton. I'm going to try to unmute Lailton. Lailton. All right. Lailton, can you hear me?
Yes, ma'am.
How are you doing today? How is life treating you?
Not good.
Uh-oh.
I'm sorry. I was laying on the couch. I've been really sick.
Uh-oh. You have COVID?
No, ma'am. I'm the one that had the DMSO on June the 5th.
Oh, okay.
And ever since I had the DMSO, I have been so sick. It's unbelievable.
What are your symptoms? What are the symptoms?
Well, I came home. I have to go to Charleston. I live in Columbia, South Carolina, so I have to go to Charleston, South Carolina, to see my urogynecologist, and he did the DMSO. I came home that night about 3 o'clock in the morning. I started running a high fever of 103.9. So I was so sick I couldn't hold my head up, and I contacted their office, and of course they recommended that I'd go get checked for the COVID, which I did. It came negative, came back negative, and Jill, I have been sick ever since.
So you need to get the doctor's notes on what happened. Let me tell you a couple of things that we know about DMSO. So number one, we have to make sure that it's RIMSO 50, that it's not another off-brand generic DMSO. Number two, one of the other things that's happened is DMSO is meant to be used in a cocktail form. It's not usually used by itself. It's usually combined with some heparin, some steroid, maybe a little of antibiotic. And the mechanism of action of DMSO is that it's a penetrant. It crosses through tissue. And it has mast cell activities. It has many different mechanisms of action. However, the other thing that it is known for doing is causing potentially irreversible smooth muscle spasm of the bladder wall if it's used at a dose over 25%. The FDA approved dose is 50%. And all that research was presented at an American Urology two American Urology Association conferences by researcher C. Suba Packer, who was the first to try to investigate side effects with DMSO. So at that meeting, there we had the best doctors in the world at that time. And so we have this DMSO study come out in the poster session. And I literally talked to every doctor I could talk to. It's like, what do you think of the DMSO research? That's pretty mind-blowing. What do you think? What do you think? And some of them said, well, it was done on rabbits, not humans, so we can't necessarily correlate with that. Others said that one doctor said it had a place, but Dr. Raymond Rackley at the Cleveland Clinic stood up when it came up for discussion, and he said, we will never use DMSO in our clinic because we believe that the vast majority of damage done to bladders that have to be removed are done by recurring DMSO installations. Now that's different than what you're talking about, but that tells you that most of the top doctors in the nation don't use DMSO so much anymore. That's a kind of a doctor treating IC out of a textbook. Right? If they say Elmiron and DMSO, it almost implies that they're teaching it out of an old textbook. But what happened to you is very, very rare. You're the first I've ever talked with in 27 years who developed a severe infection hours after having a DMSO treatment. And so I think that speaks to sterile technique. So the other thing we want to know is who created the cocktail? Did the doctor create it? Did the nurse create it? Or did a secretary or a PA create it? Because there is at least one other case, if not two, that I'm thinking of right now where somebody without medical training assembled the ingredients and they didn't use the correct technique, so they didn't identify the correct chemicals. So in your case, that speaks entirely to sterility and bacteria, the lack of integrity. And so if I were in your shoes, I would be all over that urologist and say, this happened hours after my procedure. I would want to know what DMSO is used and who assembled the cocktail, and did they reuse the catheter? As if they reused a catheter, that would be just, and it happens. That's where I would start. And I honestly would go to the FDA and I would file an urgent complaint about what happened to you if it was RIMSO 50, because if they have a contaminated lot of RIMSO circulating throughout the nation, we got to get that pulled. Something severe happened in your case, hon, and this is 27 years. This has never happened in my experience with the people that I've worked with who have had such a severe infection for so long. The next thing I would do, hands down, no choice, is I would do a next generation urine test immediately, because I would want to know what the hell is in your urine. This is, and I mean, do you feel like you're over the worst of it, or do you still feel like you're in the midst of it?
I'm over the worst.
Okay.
For sure.
Okay.
I stayed in the bed for pretty much 2 weeks. Today has been a good day for me, and I'm still not all there, but however, when I called him, and after I had the procedure done, which I'm always urinating blood. No one can figure out why I'm urinating blood.
That's infection. That's either infection or bladder cancer, or a huge Hunter's lesion. But I really doubt it. I mean, we won't. I can't tell you exactly what's wrong with you. But Hunter's lesions don't normally cause 103 fever afterwards. Everything's pointing to infection.
Well, I had lab work done, and my lab work was marvelous, off the chart.
What do you mean?
Everything was great.
I know, but that was a typical urine culture. That was not a next gen test. Listen, a typical urine culture, what they do is they grow it out. They grow it out using a growth medium. Only certain bacteria respond to certain growth mediums. And we've known the research that's happened in the last year shows that a typical urine culture will miss 95% of the potential living bacteria in your body. And it completely misses fungus. For all we know, it could be a fungal infection. We don't know. They said E. coli. They said they identified E. coli. The other thing we know is E. coli infections are, E. coli is a wicked bug that mutates quickly, that can have very, very high defense capabilities with respect to antibiotics. There's a guy named Scott Holtgren who is an amazing E. coli researcher, and he was able to prove that using an electron microscope, that E. coli changes its shape in the presence of white blood cells, so the white blood cells don't recognize it. And E. coli also creates, in the presence of an antibiotic, now, of course, this is 10 years ago, I'm sure the research has improved, E. coli can slough off its outer layer and create little E. coli seed, little passive seeds with a piece of RNA surrounded by a little liposomal coating. And it leaves that in the tissue where it just stays there passive. And then it's our own healing mechanism that turns it back on. And so that's why something like a next generation test, if not just as evidence in case they find malpractice and you can prove that you were infected with a superbug, to me, if I were in your shoes, I would be at an infectious disease specialist and I would immediately be asking for a next generation test. I would want that data.
Yeah, I called my regular doctor and I explained that to her. And she said maybe I needed to go see an autoimmune system doctor to see, which I have been diagnosed with fibromyalgia.
No, she can sign the form. Go to bladderhealth.org or bladderhealth.com, whichever one. I know bladderhealth.org. You can order the test from Microgen. It's $199, and your primary care can just sign the form. That's where you start. Is let's just see what the test shows. She's making an assumption that it's autoimmune.
Because I have lost 13 pounds. I hadn't been able to eat.
Yeah, this is not.
I've never been so sick in my life.
Well, I've never seen you. If you're still peeing blood, this is an emergency. Are you peeing red blood clots or is your urine pink?
Pink.
Okay. Well, it's not clots, so that's good. But I would want a urologist all over that. I would want the next gen testing. I would want a cancer test, urine cytology test, just out of curiosity. If you were a smoker, smoking is the number one cause or trigger for bladder cancer. So next gen test, urine cytology test. And and let's see what that says. And if you continue to bleed, I would really want somebody to look. If it were me, it's like, get in there and look at my bladder and tell me what the hell you see. Because this doesn't make sense here. If your bladder doesn't have any bloody spots, that means that you could be bleeding from your kidney.
And I don't know if you recall, it's probably been months since I spoke with you. I'm the one that had the lithotripsy for kidney stones, and it caused the 6.4 hematoma to wrap around my right kidney, and that's where all this accumulated.
Oh God.
I've got damaged nerves to my right kidney, and now they say I have IC, but
no, you're not. I mean, again, I can't give you medical advice, but this doesn't,
Please
none
tell
of this
me.
makes sense. This is not a typical presentation of IC. This is not a typical presentation of IC. It's not. However, I think you need to rule out anything and everything. Where do you live again?
Columbia, South Carolina.
So can you get up to North Carolina and go see Robert Evans at Wake Forest?
I tried to get in with him, and with me not being able to work, I haven't been able to work since everything happened October 31st of 2017. So I haven't been able to work, and I tried to get in with him, and it was like a 3-month waiting period, and it was.
It's worth it. It's worth it. Make an appointment. Just make an appointment.
I'm so afraid that I have cancer, and everybody is overlooking it.
Well, that's what I thought too when my IC started. You couldn't have told me. Nobody could have told me it wasn't cancer. I spent months dwelling on cancer. I could not get it out of my brain. It's cancer. It's cancer. It's cancer. You've missed something. I had a urine cytology test. It was negative. I didn't believe them. And I said to my OBGYN, open me up, do an exploratory. I don't believe you. I don't believe it's IC. I have to be dying. This pain is so severe. I have to be dying. And he looked at me and he said, you want me to open you up? I'll open you up. And I had exploratory surgery on September of 1993, the same month I started my first support group. Woke up in the recovery room and he said, Jill, I can tell you 100% it's not cancer. You're hurt. And so if you're at that point where you're dwelling on it, like I was dwelling on it for a good long time, the urine cytology test is a no-brainer. You pee into a cup, they send it off. It looks for markers for cancer. There's no reason why they can't do that. You could just ask for it. Just, guys, this is weird to me. I want to know. Can you please do a cytology test? It's pro forma. They would do it anyway. They should do it anyway. Anytime you have blood in your urine, they should do it. Right?
It blew me off. Like,
well,
no big deal. You know, that's just streaks of blood, and you've got small kidney stones, and it's nothing to worry about.
Well, okay, but hon, but seriously, you have a huge history of kidney stones. You have a huge history of bleeding. You had a freaking hematoma. The odds of it being cancer are slim, unless you were a big time smoker. Did you smoke? Did you smoke?
I do.
You still smoke?
Yes. I know.
Girl.
I'm trying to quit. It's so hard.
Okay. Okay. So I want you to pretend, seriously, I want you to pretend that I am right next to you every single time you look at that cigarette and that I'm slapping you across the face out of love. Out of love. It's like, listen, I grew up with a smoker. My mother smoked when she was pregnant with me. I lived in my entire life. I lived with a smoker until she had her own medical injury history and had to stop. And that was 30 years. She's 91 now. That was in her 50s. Okay. You can do it. You're going to do it. I have 100%. Yes. And you absolutely have the motivation now to do it. You understand the whys, you understand the hows. Now it's really just a question of working tortuously through that process. And you could switch to a nicotine gum, right? That would be a very good start, because at least with a gum, you're not dealing with the burned toxic smoke byproducts, which accumulate in your urine. So, you can try that. Ask your doctor for a referral for somebody to work with. You can try hypnosis. There are lots of things to do it. But the thing is, you know what? See, like, I'm looking at you right now. You are a strong woman. If it were anything else, I don't think you'd be letting anybody mess with you. You remind me of one of my old best friends, Carolyn. who I just love dearly. I loved her dearly. She's far away now, and we rarely talk, but I think about her often. And you remind me of her 100%. And to me, you're a warrior. To me, you're strong. And were it anything but this, you would be doing everything you could to protect yourself. And ironically, she has a tobacco problem too, but she chews tobacco. And it's like,
Oh,
all right, and we all have our own little crutch. So just slowly over time, nobody expects you to stop smoking tomorrow. How many cigarettes do you smoke a day?
half a pack.
Okay. Just reduce it by 1 every 2 days. Reduce it by
So
1.
I'm cutting back, but because I've been in so much pain, I wanted to smoke more, but actually I've been so sick, I don't want to smoke, but I've just got to get my hands on getting my health back.
Yeah.
I'm already going to pain management for my kidney and for the nerve damage. And I was listening to you earlier, and I was kind of thinking, I'm wondering if they're misdiagnosing me, saying I have IC, and I really have a lot of nerve damage to my bladder.
I don't know. I just don't know. But the reality is, until you stop smoking, we don't know how much the smoking is irritating your bladder. And it would be very interesting about 6 weeks after your last cigarette to see where you are, because you could be an entirely new woman. Now, what I don't, okay, and the other reason why this is so important now is that you are of a certain age, so you've lost some of that protective coating in your bladder because we're getting older, the loss of estrogen, which makes your bladder all the more vulnerable to irritants in your urine. So this is the time to start making those changes. And so to me, number one, you got to lose the cigarettes. 3 months from now, you should be done. Set a goal, do it, kick it in the butt.
Yes,
right?
ma'am.
You're just going to.
Yes, ma'am.
Yeah. Hold on a sec. Somebody over on Facebook is saying, go to the emergency room. What did I miss? Oh, Christine, you're okay. Yes. Listen, if you are peeing blood clots, absolutely. You get your tush to the emergency room immediately. And if you don't think that the doctors are taking you seriously with this now, you can still go to urgent care and say, listen, this has been going on for weeks now, and my doctors aren't taking it seriously. I have been in bed. I have had a severe fever. Can you please do a test? Christine, thank you on Facebook for saying that. I really appreciate that.
Yeah, thank you.
Squeaky wheel gets the grease. You know what, man? You got to squeak as loud as you possibly can. You shouldn't be drinking any coffee, anything like that. Are you being perfect with your diet?
Mm-mm. Yes, I'm drinking a lot of water.
Okay. Chamomile, I would doing chamomile herbal tea, peppermint herbal tea, because those have been found in research studies to be smooth muscle relaxants, so they can help calm bladder spasms. So something like that might be reasonable. Understand too that when you're in pain, your muscles get tight. So making sure that you're doing your deep breathing, taking hot showers. If heat over your bladder helps, great. If your body doesn't like the heat, it likes the cold, then do the cold. I still think it's a little bit early to. I mean, there's just too many unanswered questions for you right now, right? I don't. Yeah. So I think it's time for a few more tests. That would be my guess. Okay. What do you think?
I'm going to recommend that, and then I'm going to give you a call if you don't mind.
Not at all.
We'll go over those.
Not at all. Not at all. But I'm going to ask for a progress report. I want you down to 5 cigarettes a day in 10 days. Okay.
Okay. Yes, ma'am.
I believe in you. I think you can do it. And if you need to swap out with nicotine gum, go for it. Okay?
Okay.
Okay.
Thank you, Jill.
And listen, you have never been more prepared to deal with whatever has happened to you than you are at this very single moment. because you are truly one day older, one day wiser, one day stronger. You might not have been able to kick it a year ago, 5 years ago, 10 years ago, but you are strong now. You are stronger than you've ever been. If there is a time, this is a time. You can do it. Okay?
Okay. Thank you, Jill.
All right.
I'll talk to you soon.
Okay. Big giant hug, as always. And guys, I just want to, I just want to really remind everybody and say this. I usually do this once a year where we do our smoking cancer connection thing. And you're going to ask for a urine cytology test also, just so that you can stop worrying about it. Just stop worrying about it. But smoking is important. We have to lose the smoke. Even secondhand smoke. We now know that children exposed to secondhand smoke will have frequency urgency from the secondhand smoke. So we got to be really on it. All right. I've been talking for 3.5 hours and my throat is telling me I've been talking a lot. All right. So for the 6 people in the Zoom meeting, this is I've got one of these to give away. And then I'm going to come back to Facebook and YouTube also. But this is a special one for this. So my email, icnetwork@mac.com. I'm going to, in the chat on Zoom, hold on a sec. Okay, so this is to everyone in Zoom. I'm putting my email address in there, and I'm going to put a question in there. Oh, wait, hold on. Okay, everyone in the meeting, look, there's my email address. And what's a good question? Okay, what is the name of the instrument that is put into the bladder that allows somebody to look at your bladder wall? Okay, so this is for Zoom. Okay. Okay, so Annie.
Yes.
Okay, hon, what is it?
Oh, the instrument that you put it, is it the stethoscope?
Yes, it's a cystoscope. Okay, so Annie, I want you to email me. You're going to email me your address, and I'm going to send you this, okay?
Oh, thank you so much, Jill. Thank you.
You are very, very welcome. All right, now this is for everyone now. Now let's see. So we've got 24 watching on Facebook. Hello, you guys. Now I'm looking at you again instead of Zoom. And let's see too here on YouTube. We've got 9 people on YouTube. So this is what I'm going to do. I'm going to close out the Zoom meeting and I'm going back to Facebook and YouTube. Okay. Oh, wait, Chris just came in. Hold on. Let me let Chris in for a second. Hi, Chris. I'm not sure which Chris this is. And Chris, can you hear me at all? I see it. Okay, I'm a little scared. I see a face silhouetted. Are you an IC patient? Okay, hold on. I'm going to try to unmute you. Hello, Chris. I know you.
Yeah. Okay.
How are you today?
I'm okay, more or less.
Look at you. You look so handsome today. You look very handsome, like movie star handsome. Chris and we've known each other for a long time. How is your IC?
Well, to be honest, like it's just I think it's basically been the same for the past to some extent, but I still have trouble sleeping at night, and like it's just like I still have issues of pelvic floor dysfunction and urgency frequency.
Okay. Is it better or worse today than it was 6 months ago?
About the same. I think it's like more or less like
okay.
Just like.
Hey, can you move the camera? The camera's facing your the light in your ceiling. Can you move the camera so we can see your face? There you go. That's a little bit better.
That's kind of dark.
Yeah, that's because there you go. That's perfect. Leave it right there.
We'll see if I can.
You have a crooked lamppost back there. Okay, so are you better or worse today than you were 6 months ago?
Oh, maybe a lot the same.
Okay. And so Chris, would you mind if I shared your recent struggle with the dentist?
What I don't know if where you get all the facts from or something.
No. Anyway, Chris and I have been talking about dental work and getting dental work during coronavirus. And Chris, hey, did you see we have a red flag alert? I'm looking out my window right now, and the trees are blowing. The trees blowing down there for you? Take a look out your window. Yeah, take a look. And on Facebook, Christine is saying that for Lalton, high fever indicates infection, which could lead to kidney damage or sepsis.
The one seems okay right now.
Okay, that's good. That's good. Well, hey, dude, thank you for saying hi. It's good to see you again. Chris was the first patient I saw after my hysterectomy. I think it was 10 days afterwards. He was visiting over by my house with his dad. So I got myself in the car and had an opportunity to spend a little time with him. And it was a true highlight of my recovery. There are just people that are very, very compelling. And Chris is one of those for me. So, okay, Chris, listen, you and I can talk on the phone over the week, okay? I'm going to shut down the Zoom meeting, and I'm going to back to Facebook and YouTube, okay?
All
right, guys. Everybody on Zoom, thank you so much. I'll see you in a bit.
Bye-bye.
All righty. So the Zoom meeting is shut down, and now it's just doing that. All right. So hold on a sec. And let me move this around, and we've come back now to Facebook and YouTube. So, anyway, any last questions from you guys? Diane says, "What do you do when your bladder pain is so bad? All you want to do is curl into a ball and rock back and forth." Girl, I have been there. Number one, we have to try to figure out what kind of flare you're having. Are you having a bladder wall flare, or are you having a pelvic floor flare? The times, so if your flare began after food and you've really badly damaged your bladder wall, let's just say by drinking coffee or soda or something like that, you want to make sure that, number one, you drink plenty of water to dilute your urine. Number two, you want to alkalinize your urine, maybe with the taking a Tums or a Pre-Leaf to try to reduce the acid load that might be irritating your bladder wall and triggering all of that pain. Then you could potentially use a bladder wall anesthetic like Azo bladder pain relief tablets. Let me see if I even have them in my shelf here. Here they are. Azo bladder pain tablets. You can get these at your store. Walgreens, Walmart, they have their own brands. This is the stuff that turns your urine orange, and this can act to numb your bladder wall. But girl, listen, if you've been in severe pain like that and you can't walk and you can't function, that to me is a call to your doctor, to the on-call doctor, and maybe even heading to urgent care or the emergency room. That is not normal pain. If your pain is so bad that you can't sit, that you can't lay down. All you can do is pace and roll around. Something is going on. You need to get checked out. You could have an infection. You could have something else going on. And I would call your doctor today, tonight, and talk with the doctor that's on call. See if they can figure it out. Now, listen, if this happened after your pelvic floor, let's say this has happened after sex, or this has happened after a long car ride, or you working out or doing something you shouldn't have done, then we want to look at doing things that can relax muscles. And so that's where you want to use heat, although heat works great for bladder wall pain too, at least for me. My body craves heat. Taking a hot shower, hot bath, doing any pelvic floor work your physical therapist might have given to you, and then potentially using a muscle relaxant. If you happen to have a muscle relaxant your doctor's prescribed one for you, like baclofen or Flexeril or Valium, or maybe even CBD, if you happen to have CBD. I'm so sorry you're there right now. I have been there. I can tell you, July 4th, 1993 was the worst day of my life with IC. And it was on the 4th of July. And I'll never forget it because I literally couldn't stop moving. I couldn't lay down. I couldn't stand. I couldn't do anything. All I could do was pace and cry. But I'm living proof that you can get better. And for me, that pain was a result of I had spent a year drinking cranberry juice, not having a clue that the acid of the cranberry juice was actually making my bladder injury that much worse. Hey guys, you know what? I need to go to the bathroom. Give me a minute. Everybody, let's just go. Time for a potty break. Go get a snack. Go get your glass of water. Give me a minute. I'll be back, okay? Hold on a sec. Hold on a sec. I've been sitting too long. I'm going to raise my... Oh, wait. Hold on. I should be able to do this. Okay. Woo! I need to stand up a little bit. That'll work. Okay, why do I look like I have gray hair? Oh, yeah, because I do have gray hair. That's why. Let's see. How's that? that okay? Yeah, that's okay. That'll work for now. All righty then. It's all about being comfortable. All right, hold on. Crap. There you go. Hi, Sarah. Hi, Shelley. Christine says, suggesting a TENS unit. Yeah, TENS units can help. About that. Other thing you could do is, pain is processed very interestingly in the pelvis and actually throughout the body. The pain from your pelvis goes to your spinal cord, up to your lower brain, goes through your lower brain to your midbrain, then it goes to your upper brain. And each level does different things in the pain process. And so one of the first things that you can do for pain is distraction. Your body we've got tens of thousands of nerves that can control pain. If they were all firing at one time, we would be completely overwhelmed, right? And so the way the brain works is it only lets the most important pain messages through. And so one thing you can do is you can slap your thigh. You hear me slapping my thigh? That's a good way of diverting your brain from your bladder pain to that. I once was on a plane in a severe flare flying to England, and it was a 8 or 10 hour flight. And I had a TENS unit on the inside of my thigh doing that for me. It was distracting me from the bladder pain. So distraction works. Then in the midbrain, if it gets through the gate, spinal gate theory, and it gets to the midbrain, then it's about context. And so the purpose of the midbrain is try to determine, is this really severe threatening pain or is this mild pain? So if you're riding a roller coaster and the roller coaster hits you, throws you against the side of the car, and it hurts, but you're laughing, your brain goes, well, she's laughing, it's not that bad. But if your pain is accompanied by tears, your midbrain goes, uh-oh, this could be really severe pain, and it sends it up to the upper brain for action. Now, what's interesting about the upper brain is that you would think that it would be like a straight line, that a nerve would go to a straight line to a specific part of the brain, right? It doesn't work that way in the upper brain. The upper brain, with somebody in pain, it lights up like a thunderstorm. There's lightning storm. There's lots of different parts of the brain that light up when you're in pain. And so one of the things that really helps is if you occupy different parts, other parts of your brain with something that is more meticulous. So for example, if you, like what I used to do when my pain was really bad, is I was quilting and making dolls. I was just using my hands, and I was calculating, I was making patterns, and I had rulers, and I was busy. And that's actually, that's very, very useful when it comes to pain management. Because if you're doing Sudokus or crossword puzzles or reading a book or something like that, if you're keeping that upper brain busy, less portions of the brain can light up. And the book that I got that out of is, where is it? How you doing, Dad? Pretty good. All right. This book. This is a fabulous book. And It Hurts Down There by Dr. Angie Storr, and she is a IC specialist in Texas. And this is just a fabulous book that talks about how pain is processed and how you can interfere with the message. I mean, obviously, we want to get to the root cause of the pain. I mean, if you got an ovarian cyst or fibroids or whatever, or, a Hunter's lesion, we got to treat the cause of the pain. But this can help you understand and deal with the symptom of the pain. And one of the things that she's in here that's hysterical. Gosh, and it's just such a good book. It's so easy to read. So she talks about the lower brain, the midbrain, and she says, if the midbrain, again, if pain is accompanied by positive emotions, there's quantitatively less pain. If the midbrain is accompanied by negative emotions, there will be quantitatively more pain, which is why positive thinking matters. And actually, seriously, watching something funny, getting yourself laughing, if we can get the laughing in there, that changes context for pain. And I love this. One of the things that you can really do is, of all the techniques, very first thing she says is cuss. It's okay to swear. If you've ever hit your thumb with a hammer or stub your toe on a table, you probably sworn, or at least wanted to. This kind of reactive vocalization starts in the lower brain gateways. It's a spontaneous reaction to pain, and it actually reduces the pain signal. This only works well when you're not accustomed to using foul language regularly. And if it's against your morals to use foul language, she writes, my challenging right now, then you can skip this technique and move altogether. Yeah, I swear frequently. Not usually on stream, but believe me, the last 3 years, I've sworn a lot. All right, let's go back to your questions. Diane says, azo makes her sick. All right. Diane, in some cases, doctors will teach you how to do a rescue installation at home. So, if you're one of those people where your bladder wall is just every now and then, hits you hard, you could do a rescue instill with lidocaine, or you could do, if pain is more chronic, you could do Peora. Right? We have the research study that shows that palmitoethanolamide can be very, very good for reducing the pain of IC. But also, too, you can look at some of the supplements like Bladder Builder, Bladder Rest, Cystoprotect, things like this might also be helpful, especially if you've got an issue with your bladder wall IC subtype 2. We didn't really talk about the subtypes today. Sahar says, did anyone have IC and felt better during and after pregnancy? I'm pregnant now. My pain is so much better. Yeah, that's Sahar. Congrats. Very, very common. About half of the IC patients female patients who get pregnant, their pain goes away. And then for the other half, the pain tends to be a little bit worse. So you are in the first group. So congratulations. That's completely normal. And that's wonderful. And we have a pregnancy resource center on our website, icnetwork.org, if you want to go check it out. Diane says, I haven't seen my doctor yet. I don't go until July 14th. Hold tight. It's only 2 weeks away. My birthday is July 12th. No birthday party for me. That sucks. You know what? It's a big birthday for me. I would have loved to have had a big party, but not that I would invite, I would just invite family. So we're going to be doing a little birthday party online for everybody whose birthdays have been messed up by COVID. Sarah says, Tums works well for her. Yeah, totally. Shelly says, I work jigsaw puzzles a lot and really helps with pain. Yeah, it does. It really, really does. We've done 6 jigsaw puzzles so far. I need to put a new one out. Diane says, could somebody email the list of meds to try? Not really, Diane. You have to come over to our website, icnetwork.org. And the first thing you have to do listen, we can't talk about therapies until we understand anatomy. Anatomy here. You know what? Let's do it. Let me get my slides here. Hold on a sec. Whoops. We haven't done this yet today. And so let's just do it now. So hold on a sec. So let's see if we can kickstart you. And Diana says you don't look sick. Thank you. Hey man, I'm young. I'm 25 up here. Okay. All right. You know what? Let's do it. I've got the energy. I want to do this. I want to keep going. So for Diane and for Donna, because Donna is over here on YouTube right now. Donna is saying nothing's working. I am, let's see. I'm going to have this bladder out ASAP. Okay, so hold on. Okay, so you guys, so come on, let's do this. Let's do this. I'm going to give you the spiel I give to everybody who calls me. Lily says, how do you explain how several IC patients on YouTube shared how they cure IC? Lily, I'm going to explain that. So let's think about this for a moment. Now listen, if you actually spent time with a group of IC patients, and let me shut this door, hold on. Okay. Now, if you ever spent time with a group of IC patients, the thing that stands out the most is how diverse they are. For some people, IC begins in childhood. For others, IC begins after menopause. For some, IC begins after chemotherapy. While for others, IC begins after they fall and they break their teeth. There is tremendous diversity in this patient population. All those patients have been diagnosed with interstitial cystitis, but are they the same? No, they're absolutely not the same. And we still see that diversity in symptoms. Some of you have terrible pain. Others have absolutely no pain. Some of you might have damaged bladder walls or Hunner's lesions. Others have absolutely normal bladders. You've all been diagnosed with IC, but are you the same? No, you are not. Now, 20, 30 years ago, we all assumed that IC was a bladder wall dysfunction. But what changed that was in 2008, when the National Institutes of Health released their first pelvic floor physical therapy study. And interesting, you go back 50, 60, 70, 80 years, and you look at the journal articles for IC, almost every single one of them talks about tight muscles. Muscles so tight they resemble tight piano strings. And yet in all that time, all those urologists were going bladder, 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 bladder. But they're describing tight muscles, but bladder, bladder, bladder. All their focuses were on bladder. And then there was a physical therapist, Rhonda Cotterinos, who went to a National Institutes of Health IC meeting and said, guys, in my practice, I have been able to heal patients with physical therapy. I think muscles are involved. And she went to some federal meetings and they laughed at her. They laughed at her. They put her on the agenda. She was the last speaker on the agenda, starting at 5 o'clock. Half the room, more than half of the room walked out. Wouldn't even listen to her. Wouldn't even listen to her. She's a true hero in the IC world. But she was able to, they were able to create a case to get the National Institutes of Health to fund a research study on pelvic floor and IC. And what do you think happened? The data was stunning. The data proved that pelvic floor physical therapy was more effective than almost every other therapy ever tried for IC. And when that study was published in 2008, the entire IC world had to go, uh-oh, wait, what? What? Muscle work? Reduced IC symptoms? What? Because if muscle work reduced IC symptoms, then maybe for some of you, it's not your bladder. Maybe for some of you, it's your muscles. It's your muscles. And remember, you go back almost 100 years and you look at the case studies and the papers, they're all describing tight muscles. Fascinating. So it was in 2008 that the IC world blew apart. And people had to go, maybe it's not just the bladder. Maybe it's the muscles. And now, since that time, more and more doctors and clinicians and researchers around the world are now exploring these interesting, unique presentations of IC. So as an example, we know that fibroid tumors that push on the bladder will give you the symptoms of IC, frequency, urgency, pressure, pain. And we also know that when the fibroid tumor is removed, that most of the bladder symptoms go away and that patient is cured. We also know that for patients whose symptoms began after a muscle injury, that they can be cured with muscle work. But we also know that there might be some variants of IC that might be harder to work with. So for the last 10 years or so, there's been this big debate among the top doctors in the world. What are the variants of IC? What can we agree upon? Because clearly not everybody is the same. So at that upper echelon level, there is a tacit agreement that a patient with a Hunner's lesion is its own unique group as compared to everyone else. So, and I have a picture of Hunner's lesion. Let's see. So let's look at this picture for a moment. This is 16 Hunner's lesions. These are big bloody wounds. And they're known, so they have a center, a very irritated center with arms that usually stretch out. It's called a stellate appearance. And when you biopsy a Hunner's lesion, there is massive inflammation. There is a war happening. Inflammation means your body is fighting something. There is a war happening in this patient that is not happening in other patients. The patients without Hunner's lesions, they do not find inflammation in the bladder wall. So this represents maybe 10% of the IC patient population. And here's what we also know about Hunner's lesions. These patients don't respond well to therapy. They have failed pretty much every traditional bladder wall therapy, like Elmiron, doesn't work. DMSO doesn't work. Rescue installations might numb it, doesn't really work. So everybody agrees around the world pretty much that somebody with Hunner's lesions, that's probably its own unique disease. Everybody else would be called urologic chronic pelvic pain or bladder pain syndrome. So let's go back to this for a moment. So what the hell causes a Hunner's lesion? It's fascinating. There are two, this is kind of one of the mysteries. Why do Hunner's lesions develop? There are two dominant theories, but there are more. But the two most dominant theories are, number one, that it's a virus, that it's a viral infection. And it was researchers in Europe who studied the urine of patients with Hunner's lesions and found virus. And they found a couple of different viruses. They found the polyoma BK virus. The polyoma BK virus is a virus we all have. It's a normal part of the human virome. It gets turned on in patients who are immune compromised. So if a patient has had a kidney transplant and they're on immunosuppressant drugs, hemorrhagic cystitis is common because the polyoma BK virus infects the bladder wall and causes the bleeding. And again, when we look at the biopsy results showing massive inflammation, war, could it be a virus? Now, we've had a couple of research studies from Europe. They've identified a couple of different viruses, the polyoma BK, Epstein-Barr. There's also discussion with human papillomavirus and herpes as playing a role. And when you think about bladder infections, y'all think about bacteria. You got to stop thinking about bacteria because viruses are possible and fungus is possible. The second theory on a Hunner's lesion is that it is a nerve that is stuck in an on position, that it is a nerve that is massively inflamed. Because an inflamed nerve will release a substance called substance P, which damages tissue. It damages tissue. And so the other possible source for a Hunner's lesion go right back to tight muscles. In a somatovisceral reflex, muscles that are tight compromise blood vessels and nerves, and that compromised nerve becomes a sick nerve. And a sick nerve releases substance P. And so that can also be a source for this. Okay. So we know Hunner's lesions are a unique group, but clearly there are more. And you, my friends, are an anatomical mystery to be solved. Because for some of you, IC might have begun again after falling. For others, IC might have begun after chemotherapy. So there's this competition around the world of doctors who are trying to define the variants, define the subtypes of IC. And in Europe, the European Society for the Study of IC Bladder Pain Syndrome, they have a system that has a minimum of 12 variants of IC, and they make it based on biopsy results and what they see in your bladder. Now, we don't do that here in the United States because we won't pay, our insurance companies won't pay for that testing. In Canada, they use a system called U-Point, where they look at your bladder symptoms, they look at biopsy, they look at infection results, they look at muscles, they look at other pain syndromes, they look at stuff like that to try to create a unique picture to treat you as an individual unique patient. In the United States, we don't have a nationally agreed upon subtyping system. And there's a lot of debate, you got to understand that. I just read another article this morning about it. There's a lot of reluctance to jump too soon. It is what it is. Geeks like me and like researchers, we like a lot of data before we make assumptions. But sometimes it's okay to make assumptions too. So it was Dr. Christopher Payne who ran the IC research program at Stanford University, who came out about 5 years ago with a proposal. He said that he believed that there were 5 core subtypes in the IC patient population, but then each of those subtypes could have subtypes. And in my opinion, he nailed it. At least from the perspective of helping you understand the many things that can be contributing to your pain and discomfort, his system rocks. And, one of the points that he made in his article, and he made a very interesting correlation because he basically said, we should be treating IC patients like cancer patients. And of course, I'm reading the article going, oh my God, don't say cancer. Why would you say cancer and scare patients? Because there's no connection between IC and cancer. You got to understand that. But if you read the article, what he says is, think about it. When somebody's diagnosed with cancer, they don't just say you have cancer and walk away. They tell you you've got cancer of the left breast, that it's estrogen dependent, type 1, 2, 3. You're given a very, very narrow, specific diagnosis so that when you walk out of the doctor's office, both you and your doctor have a very clear, intuitive treatment plan. And he argues that when you're diagnosed with IC, there's no intuitive treatment plan. You don't know what to do next. You don't. In many cases, your doctor doesn't know what to do next either. There's no intuitive pathway. How do we give you an intuitive pathway with a more specific diagnosis? So he proposed 5 core variants. So let's go through his variants. Let me get a drink of water here real quick. All right. So using his system, and this is what I've been using now for 4 or 5 years in my coaching, and it's working really well. I'm just telling you right now, it's really helping patients understand their symptoms, and it's helping you explore new and different treatment options. And let me just say this too. One of the things that Dr. Payne said in his article is how unfair it is to tell patients that IC is an incurable bladder disease. When some of these subtypes, the bladder is a secondary victim of another issue. That some of these subtypes are curable, specifically curable. Okay, so let's go over his system. System number 1, Hunner's lesions. Hunner's lesions. So he, like the rest of the IC world, believes that Hunner's lesions represent a completely different disease process. And he's right. And what you may not know is that lesions respond well to lesion-specific therapy. So today, rather than throwing lesion patients on Elmiron for 20 years with no success, Lesions are generally injected with a steroid. They might be cauterized. You might have hyperbaric oxygen therapy. You might have plasma-rich therapy. And we even have a therapy that has cured Hunner's lesion patients in just 2 weeks. And it's called Liris, L-I-R-I-S, Liris. Liris is interesting because Liris was created at MIT as delivering medication to the bladder for 24 hours a day. Because the problem with delivering medication to the bladder is you pee it out. How do you get medicine to stay in the bladder to be effective? It's freaking hard. So imagine a soft, hollow piece of spaghetti filled with medicine. And what they did is they put it in the bladder where it kind of folded itself into they call it a pretzel, so that it couldn't come back out. And inside this soft, hollow piece of spaghetti was medicine, lidocaine, a numbing agent, a numbing agent. Now, what's so interesting is the first medicine they chose for Liris was lidocaine. The first study done up in Canada was on like a dozen patients, half of whom had Hunner's lesions and half of whom didn't. They took a hydrodistension before and they took a hydrodistension afterwards. And guess what happened? The lesions disappeared. Now think about it. Lidocaine turns nerves off. It's a numbing agent. Isn't it interesting that when you turn a nerve off, a lesion goes away? Which again kind of points to a theory that it's either a nerve that's stuck in a massive inflammatory situation, or it could be a virus on the nerve, potentially. So anyway, Liris is what just stunned everybody, that it actually healed lesions. And in many, many studies, doctors around the world saw Liris healing lesions. Unfortunately, the company has shelved it. They shelved it last year. They didn't think it would, they didn't say why, but I think it was about money. I don't think they thought it was going to make a profit. So we are continuing to ask that it be unshelved because it cured some patients. So there you go, Hunner's lesions. Let's go to the next subtype using the Chris Payne system. The next subtype is bladder wall driven. Because hello, the bladder, like any other part of the body, can be injured. But how is the bladder normally injured? Usually, it is going to be injured through some sort of chemical exposure. Chemotherapy is a perfect example. So these are the patients whose symptoms began after some sort of chemical trauma to the bladder wall. So we're talking chemotherapy. We're talking a horrible diet. If you're drinking diet soda all day, if you're not drinking water, there's going to be a toll. Your body was not designed, your bladder was not designed to hold acid all day, every day for years. Eventually, that tissue is going to break down. So chemical injury from food is real. There are a couple of other things that can happen. The third thing that we want to look at is estrogen atrophy. Because what makes the bladder so unique is that it's the only organ in the human body designed to hold toxic waste. Because urine is body waste. Urine contains ammonia and urea and all sorts of other harsh toxins. So how can the bladder hold ammonia for hours at a time and not get damaged? And the answer is how it's built. It's ingenious how it's built, because your bladder is like your mouth. It is wet. It is a hollow organ covered with mucus. And it is this nice, thick, mighty mucus that acts as a barrier between what's ever in your urine and what's ever on that skin. So here is a three-dimensional picture of your bladder wall. Now, obviously, your bladder is not freaking blue. Okay, that's just for graphics. You've got an outer coating of mucus. Underneath that, you've got four layers of urothelial cells. These are the largest cells in the human body. Then underneath that, you've got blood vessels and nerves and mast cells. Okay. Unfortunately, this nice thick coating of mucus is estrogen dependent. So when you're young and you have lots of estrogen, you got lots of mucus. When you're older and you have less estrogen, guess what? You have much less mucus. So what that means then is that the irritants in your urine are now reaching the cells and causing damage. So we call this estrogen atrophy, or the genitourinary syndrome of menopause. It is not a disease, it is aging. We don't treat it like a disease, we treat it. Our goal here is to try to give that skin what it needs to produce more mucus, which is usually estrogen, or to give you sort of protective coating that might fill in the areas that are slim. And that is why this is one of the old Elmiron educational sheets. This is how they explained how Elmiron worked. It acts as a coating to go over those thin areas in your bladder. If your symptoms began after hysterectomy or after you started Lupron, or you're in your 40s or your 50s and things are starting to dry out, listen, if your vulva is dry and your vagina is dry, then so is your urethra and so is your bladder. And the urethra is kind of like the canary in the coal mine. The urethra is usually the first part of the urinary tract to start screaming when your estrogen levels to drop to a certain point that skin is not strong anymore. And so if you feel like there's a drop of urine stuck in your urethra, or your urethra is very tender, or is burning as you're peeing or as urine is coming out of your body, if your urine feels hot and you're having burning on the outside on your vulva, we call that urine burn. That is estrogen atrophy. That means that your vulvar skin is also struggling and doesn't have a nice thick coating of mucus. So the common therapy for estrogen atrophy might be using an estrogen topically, if you can do that, as well as some sort of coating. Then the last group in this subtype of bladder wall driven, of course there are probably others, is chronic infection. Chronic infection is possible. It's not in everybody. I really disagree with those people who insist that everybody has a chronic bacterial infection. Research has proven that that's not true. But some of you could have a chronic infection. You could have a chronic bacterial infection, or what the National Institutes of Health continues to find is chronic candida, fungal infection. And the last research study that was released earlier this year actually identified up to 13 different species of fungus living in the urine of some IC patients. And the more species you had, the worse your pain. The worse the pain. And of course, that's ultimately the flaw in people who should do long-term antibiotic therapy. Because what is that doing? That is creating a perfect culture for fungus and candida. Because antibiotics kill the biome. They kill the good biome that normally keeps candida in check. So, my friends, the way that you can figure out if you do have a fungus infection is going to be with something called next generation DNA urine testing. And it will identify everything living in your bladder, good bacteria, bad bacteria, fungus, and if you order a specific test, even viruses. And so one of the signs of a fungal infection is, do you flare with sugar? Do you flare with carbs? Candida have to feed, and anybody who's had a drug-resistant candida infection, like a candida glabrata infection, myself included, you know that when you eat sugar, yeast flares. And so if you notice that your bladder symptoms get worse after eating carbs and sugar, that's a pretty good sign that you could have fungus. So that's one of the things that is doing all of these testing, all the viral testing and the fungal testing that's been done in the last 4 to 5 years by the National Institutes of Health is all using next generation testing. This is the future. Typical urine tests will not identify funguses and viruses. This will. Okay? So that's IC subtype 2, bladder wall driven. Okay? So let's go to IC subtype 3, which is really the biggest subtype. IC subtype 3 is pelvic floor driven. So these are the patients whose symptoms began after some sort of physical trauma, a car accident, a fall, a rape, a history of athletics where you fell, being a paratrooper, being a wrestler, being a football player, being a ballerina, being a dancer, being an ice skater, something that involves trauma to the pelvis. And I talked about this at the beginning part of this meeting, and this is the book that you must read if you have a history of injury in your before or when your symptoms began, because this is the book that explains how a muscle injury can cause your bladder wall also to start breaking down. So I call it the chicken versus the egg dilemma. Which comes first, the chicken or the egg? And for us, it's which comes first, the bladder or the pelvic floor? They're both involved. They cannot not both be involved. They are incredibly interconnected, but one is normally driving the other. So if your symptoms began after chemotherapy, so the chemicals from the chemo have creamed your bladder, man, your bladder is screaming in pain. Or let's say you use ketamine, your bladder is screaming in pain. Your muscles are going to get tight in a guarding reflex to protect you, right? We can't turn that off. That's subconscious. But our treatment priority for that patient is to calm and soothe the bladder wall. So we know that if we can get rid of the chemicals, if we can dilute the urine, comfort and soothe the bladder, we know that as the bladder calms down, the muscles will release and that patient will be in a better position. But think about the patient whose symptoms began after a muscle trauma. So I'm thinking about, I'll give you a true story. A 22-year-old guy whose symptoms began out of the blue. Very good high school athlete, football player. And all of a sudden, frequency urgency pain, severe, got worse, couldn't go to college, stuck at home, incredibly depressed, incredibly frustrated, feeling left behind. Y'all know what I'm talking about because this happened to a lot of you too. You stuck at home and you don't know what the hell's going on with you. None of the bladder therapies work. None of them work. And so he's gone to a couple different doctors, become very depressed. Doctors aren't helping him. His mom calls me. She goes, I'm trying to help my son. It's like, okay, cool. Can I talk to him? She's like, well, let me talk to you first. So I talked to her for a while, and it's like, okay, it would really help if I could talk to him. So he called me back a couple days later. He goes, yeah. It's like, okay, it's me. It's like, all right, dude, so let's have a chat here. Tell me, did any event trigger this? Can you remember anything happening that began this for you? He goes, yeah, I can tell you exactly when it started. How? My football team went on a ski trip. We were on a ski lift. I fell off the ski lift on my tailbone. That night, frequency urgency pressure pain. I said, did anybody ask you about that? He goes, no. Did you tell anybody that it began after you fell off the ski lift? He goes, no. There's a classic case of somebody whose symptoms began after a muscle injury. And you know what? We're seeing a lot of tailbone injuries now. We're seeing a ton of tailbone injuries. And that really fascinates me. I can remember breaking off the tip of my tailbone in junior high. And I had my first symptoms of frequency urgency in 7th grade, right around that time. So if your tailbone is centered off of your spine and it has a little curve to it. But if you break it, it can heal to the left, heal to the right. It can be crooked. It can do all sorts of crazy things to your muscles. So, but again, now in his case, his first symptom was frequency urgency. He goes to the urologist. The doctor goes, it must be infection. They gave him antibiotics for months. Didn't work. Goes back to the doctor. Doctor goes, must be prostatitis. Gave him prostate meds. Didn't work. Went back to the doctor. Doctor goes, must be interstitial cystitis. Gave him Elmiron. All that. Didn't work. Nothing worked. And the reality for him and for that injury patient is no bladder therapy is going to help. You're going to spend years on bladder therapies. You'll never get better because the fundamental problem is not the bladder. The fundamental problem is poor blood flow from tight muscles. Poor blood flow from tight muscles because when you fall, bam, you get a compression injury. A muscle fibers are compressed. They're damaged. They're weakened. When you fall, blood vessels are compressed. If you have bruising, that proves that you had broken blood vessels. And when you fall, nerves are compressed. And what you don't know is those nerve fibers have little tiny blood vessels in them, and those rupture. And it becomes a compression injury in the nerve fiber itself, and then the nerve fiber is damaged. Okay. And then we get something called somatovisceral reflex, where these damaged, sick nerves, the dysfunction in those nerves spreads up to the spinal cord, where the bladder nerves are, and then the bladder nerves become dysfunctional. Those nerves start releasing substance P, which damages the bladder wall, which generates your frequency urgency. But that's not the fundamental problem. The fundamental problem is a freaking compression injury. You've got tight trigger points that have disrupted blood flow and are disrupting nerve function. And this is the book that explains it. It explains it. The pictures and illustrations in this book are stunning. Let me see if I can find the compression one. The compression one is it just blew my mind. The one thing about this book is that they did not do an index. It took the doctor 15 years to write it. It's a love letter to his pelvic pain patients, but they just wanted to get it out. And so they did not do an index. So you kind of have to dig through it to find the stuff. I just saw it. Hold on. The section on trigger points is just wonderful. Absolutely wonderful. Is that it? Yeah, here it is right here. Okay, look. So here's a normal healthy nerve. And here's a compressed nerve. And explains the biology of this and how that creates dysfunction. Okay. So our therapeutic priority using the CRIS pain system for this group of patients is to restore blood flow. So how do we differentiate between bladder wall versus pelvic floor? It's often with symptoms. So bladder wall pain is very sharp and shrill. It feels like razor blades. It feels like ground glass. And the fuller you get, the worse you feel. So here's a picture. This is a picture of an injured bladder wall. Okay, this is not Hunter's lesions. This is more of an injured bladder wall. So imagine what happens as you get fuller and fuller and fuller and fuller and fuller. Urine is getting into those wounds, and that triggers pain. And then when you pee, bam, urine is off of the wounds, and you feel a sense of relief. So if you have pain as your bladder fills with urine that is relieved by urination, that points us to your bladder wall. But a lot of you have pain after you're done peeing. Or pelvic floor pain can be a pulling sensation or a pushing sensation or a vibration. The classic symptom of somebody with tight pelvic floor muscles, well, obviously pain with intimacy, especially for women if your pelvic floor, but for men too, if your pelvic floor muscles are tight, sex is not fun. But the classic symptom of tight pelvic floor muscles is that you cannot start your urine stream right away. You are sitting or standing there 5, 10, 15, 20, 30 seconds before you can release your urine. That is the #1 symptom that you have tight dysfunctional muscles. And so any good urology clinic now should be assessing your pelvic floor at the very first appointment. It takes 5 freaking seconds. They glove up, put a lube on their finger, and stick it where the sun doesn't shine. And if your muscles are tight, they immediately send you to pelvic floor. And listen, you can't, I know in your brain, you're thinking, it has to be my bladder. It has to be my bladder. It has to be my bladder. There was one gentleman I was working with, an Ironman athlete. We were talking on the phone. He called. He was in deep distress. His symptoms were very, very severe. We start talking about his symptoms. And I'm like, dude, think about what you do every day. You know, you work out massively. You've been on a bike for thousands of miles. And his symptoms were far more suggestive of pelvic floor than bladder wall, but he didn't believe me. He goes, I don't believe you. I'm peeing all the time. And he called over a period of 6 months, progressively worse every time, until finally he was crying. And it's like, dude, did you get your muscles checked? He goes, no, I don't believe you. And I'm like, what the hell do you have to lose? Go have them check your muscles. Let's see. You're an Ironman athlete. Your pelvic floor has to be compromised from sitting on a bike for so long. At least have them checked. He finally did. And he called me back from his car and he goes, oh my God, I have a massive pelvic floor injury. It's like, yeah, your pelvic floor muscles can cause all the symptoms that you associate with your bladder. Okay? All right. Let's go to the next subtype. Now, and again, in the Chris Payne system, he argues that IC subtype 3, the largest subtype, is curable because it's a muscle problem, and muscles respond beautifully to muscle therapy. I had, as I've said many times, terrible muscle spasms after my hysterectomy, and pelvic floor physical therapy fixed that. But you got to do it. And listen, if you go to, so when you get referred to a pelvic floor physical therapist, here's the reality. At that first appointment, it is their job to evaluate your body. They're going to measure your legs. They want to see if you have one leg longer than the other. They're going to look at your core. They're going to look at your hips. They're going to look at your glutes. They're going to look for muscle tension and muscle weakness. They're going to have you walk up and down the hallway, see how you're walking, because if you're walking weird, that's going to be reflected in your pelvic floor. And then they're going to do an internal exam where they're going to gently touch muscle groups, because you got a lot of muscles there. You got 3 layers of muscles. You've got muscles that go from left to right, front to back, low to high, and there's 3 layers of them. So they're just going to be gently touching muscles all over the place. If they can touch a muscle and trigger your pain, that is a hallelujah moment. Oh my God, that's it. What are you touching? You want them to find something painful at that first appointment. Do not be afraid of pain, because if they can touch something and reproduce your pain, that is a victory. That is exactly what we want. That is a hallelujah moment. And your job then is to ask, what are you touching? And we need to get them to identify muscle groups so that they can start working on those. Mine is on my left side. It is my left piriformis muscle. And the reason why my piriformis muscle is weak and spasming is because I have SI joint dysfunction as a result of scoliosis and being an athlete. And so my piriformis muscle is my beast and burden. It is vibrating right now, which is why I moved from sitting to standing. And so I can't cure my scoliosis, and I can't cure the fact that I was an athlete that hurt myself. But I know what to do to fix it. And I'm not scared of it anymore. I'm not scared of that pain. I know what it is. I know what to do. I know what's involved. And a lot of it is going to be internal muscle work, my friends. It's going to be using internal muscle work. When I feel those muscles getting tight, it is a wand moment. And not just a moment, it's consistent use. Okay. Now listen, if you've had muscle issues for decades, 5 physical therapy appointments are not going to fix it. Not going to fix it. You're in this for the long haul. For the long haul. And we got to try to figure out why those muscles are so chronically tight. It could relate to your feet and how you're walking. It could relate to a hip. It could relate to knees. It could relate to anything. You are an anatomical mystery to be solved. And again, this book is the book that will help you figure it out. This is a beautiful book. Beautiful, beautiful book. And it's free on Kindle Unlimited. So there are no excuses. If you have a Kindle and Kindle Unlimited, it's free. Get it and read it and study it. You can buy the print version in our store. Okay. All right, let's go to the next subtype. IC subtype 4 is pudendal neuralgia. This is a nerve injury. So think about it. IC subtype 1, Hunner's lesions. IC subtype 2, bladder wall injury. IC subtype 3, pelvic floor muscle injury. IC subtype 4 is a nerve injury. So how do we know somebody has a nerve injury? Well, it's usually shooting electrical pain, like sciatica pain. So if you have a zinging pain down your leg, or if you have positional pain, you're fine when you stand, but when you sit down, it hurts and you can't sit down. Or when you bend over, it hurts. Or when you squat down, it hurts. That's a sign that you have a nerve, usually your pudendal nerve in your pelvis, that is being compressed in some way. Usually it's compressed by very tight muscles. And so the therapy for pudendal neuralgia might be a nerve block to silence a nerve, but we've got to try to figure out why the nerve is compromised in the first place. And again, usually it might be from scar tissue, it might, from a previous surgery, it might be from very, very tight muscles, it could be anything. And there are specific therapies that are used for nerve injuries. You could do nerve calming, like Neurontin. You could do, again, Peora, and all the PEA research studies has been found to be particularly helpful for people who have nerve issues. Tammy says, thank you for everything you do. I talked to you on the phone over 25 years ago. Tammy, how did 25 years happen? It's crazy, right? It's crazy. All right, so if you've got the electrical pain, the burning pain, the searing pain, pain with movement, if you can't sit down, that speaks to your nerves. If you've got persistent genital arousal disorder where you feel this really weird, creepy, icky arousal sensation that kind of like feels good, but also feels absolutely horrible at exactly the same time, that is a sign that your pudendal nerve is being compressed. If you have numbness in your skin, lichen sclerosis is an example of a very severe nerve dysfunction of the vulva. So what he talks in this book about how he evaluates the skin to look for deeper nerve injuries and even subcutaneous tissue. Subcutaneous tissue is the tissue underneath your skin. And what he found is that some of his pain patients had nerve dysfunction in the sub-Q tissue. So what he did is he used infusions of lidocaine right underneath the skin, which turned that nerve off, calmed that nerve, and gave that patient peace. And so there you go. IC subtype 4. The last subtype in this system is bladder pain syndrome central sensitization. And this is also my subtype. I'm IC subtype 3, IC subtype 5. So what is central sensitization? Central sensitization means that the nerves throughout your body or in a specific area of your body are more sensitive and easy to turn on. Hello, redhead, fair skin, Norwegian, and Swedish. The epitome of somebody who is sensitive. People with central sensitization, it's often inherited. It's absolutely inherited in my family. It goes back generations in my family. Hello, redheads. But it also can happen after a major nerve injury where a nerve gets compromised and other nerves in the area also get compromised. So what are the symptoms of central sensitization? Very sensitive skin. And oh my God, now that I've gotten older, my skin is much more sensitive. It's ridiculous. I have to wear my pajamas inside out because I can't stand seams under my arms. It's ridiculous. So we tend to have very sensitive skin. We tend to be drug sensitive, where we just can't take normal doses of medications. We get lots of side effects. So we take half doses, quarter doses, pediatric doses. We tend to be food sensitive. There are some foods that just don't work in our body, not just our bladder, our whole body. For me, it's oatmeal and chocolate. If I eat oatmeal, I have bowel spasms for 48 hours. Chocolate destroys me. I have bend over and screamers. Like literally, I cannot walk. I'm in the fetal position on my floor in my bathroom with bowel spasms from chocolate. It's just, and it makes sense because chocolate comes from Africa and my family comes from the Arctic Circle. So my lineage, my body doesn't know how to process chocolate. It just doesn't. It's poison to me. It's just absolute poison to me. Evolutionary adaptation has not happened for my generation, for my lineage. It takes 5,000 years for an adaptation to occur. We've only had chocolate for 1,000 years. My body just doesn't know what the hell to do with chocolate. People with central sensitization are very chemically sensitive. We don't do well with scented candles and Febreze and stuff like that. And the odds are if you have central sensitization, you've already gotten most of that out of your home because you know it hurts. It's weird that a smell can hurt, but that's the other symptom, is we have a wicked sense of smell. Man, we can smell things other people cannot smell, and smells drive us crazy. Whether it's a bathroom smell or whether it is oven cleaner or fabric softener, they bother us. The boyfriend I had when my IC started, I won't say his name. Actually, I haven't seen him in 30 years. I don't know where he is. I hope he's happy. Truly hope he's happy. I used to freak him out because he would come home from work and he would kiss me and I could tell him exactly what he ate that day. Exactly. He would just look at me like I was a nut. How can you tell that? And it's like, that's what happens with people who have a sensitive nervous system. We smell more and we taste more. And we can be visually sensitive. If there's a funky pattern in a carpet or a wallpaper, we have to close our eyes and turn away. We can be sound sensitive, where some sounds drive us crazy, like a cat meowing or a dog barking. People who are sensitive also tend to be remarkably empathic, especially animal empath, which I think is also very, very interesting. So central sensitization is not a disease process. In some cases, it's your landscape. It's your lineage. It's how you were born. So if when you were a kid, people said, oh, you're just sensitive, just get over it. It's like, listen, you can't get over how you're hardwired. Your nerves have a lower action potential. They are simply easier to turn on. And so our therapeutic priority for this group of patients is to calm nerves. And this means that we as patients have to be remarkably attentive to those things that bother us and try to avoid them. Like for me, I hated working in the city. The work was easy when I worked for the feds. The work was easy. Could have done it with my eyes closed. It was the smells. It was the sounds. It was the drives, although I was miserable. It's too much. I'm better in the country, which is where I am now, in the heart of fire country. I like a quieter environment. I don't like a noisy environment. I don't like going to, country fairs and spending hours at a time in groups of people. Granted, we're not doing that now. I am kind of a quieter, more reserved person. And that's how my body thrives. And that's one reason why I'm better, is I don't push it. You can't avoid life. I still go to the city and go to conferences. I don't enjoy it. Much happier when I come home. So that's central sensitization. So using the Chris Paine system, we've got 5 core variants, and that helps us figure out the right therapies for that patient. If you have clear pelvic floor driven symptoms and your bladder wall looks normal on cystoscopy, that's great news. Your bladder wall looks normal. You got to work on your muscles. Why would you waste money on bladder stuff when your bladder wall looks good and your pelvic floor muscles are tight? You need to focus your money on working on your pelvic floor, and vice versa. And so subtyping gives you a very clear, intuitive treatment pathway. But here's the issue. This is only being done at the upper levels. And even then, there's a lot of competition. And so your local doctors are not going to know about subtypes. Regional doctors are really probably not going to know about subtypes. It's really the national doctors, and they all have their own subtyping system. They'll have their own variants. So I'm just sharing with you the variant that Chris Paine developed that I happen to use on the IC network that I absolutely love. So getting back to the original question, what do I think about those people online on YouTube who say they're cured? Number one, you cannot believe blanket statements. If somebody online says everybody has chronic infection, you all should be on antibiotics, they are wrong. 100% wrong. Because it begins with a proper diagnostic workup. And if you've got tight muscles, those muscles need to be addressed. If you've got Hunner's lesions, which could be viral infection, antibiotics would be a complete waste of time. And so there's no blanket statements here. You are a unique entity. You are a snowflake. Every snowflake is different. You are an anatomical mystery to be solved. So when you go to a new doctor and you get a second opinion, I don't want you to walk in and say, I've got interstitial cystitis. Please, God, don't do that, because you will drop down the rabbit hole of whatever beliefs they have. You have to walk in fully prepared to talk about your symptoms. Hey, doc, I have got this weird pain on my left side of my scrotum. Or, hey, I've got this pain by my hip bone. Or, you know what? I've got this burning pain, but it happens as I'm peeing or on the outside. Your ability to verbalize the nuance of your symptoms is going to determine how successful you are. Is your pain inside of your body? Is it outside of your body? So is it internal or external? Is it high or low? Is it left or to the right? What does it feel like? Does it burn? Is it sharp? Is it dull? Does it ache? Are you being zinged? Does it feel like you've been hit by an electric circuit? What makes it better? Lying down? Heat? What makes it worse? Food? Sex? Sitting in a car? Are there any really weird symptoms? Symptoms that you just really, honestly, you would never think of sharing with your doctor, or symptoms out of embarrassment you might not want to share, like, again, persistent genital arousal disorder, where you're feeling this really weird, painful arousal sensation. And you're thinking, I call it one of the dirty secrets of IC, because when it happened to me, I had it for about a month. And it was creepy as hell. I hated it. I was really embarrassed. I didn't want to tell my doctor. I don't even know if I told my doctor about it, because it went away. But that is a very clear sign that the pudendal nerve is being pressed on in some way. And they can do a nerve block for that. And if they can do a nerve block and turn that pain off, then we know the source of your pain, which is the pudendal nerve. So I take great exception to anybody online making all or one statements about IC. I do. And now again, you know, I have on our website this exhaustive list of confusable diseases now. And one of the things that I highlighted in our magazine, so I had I've always had a group of patients who would say, you know, Jill, the pain gets worse and worse and worse as the day goes on, until by the end of the day, I feel so much pressure and I feel like I'm carrying a bowling ball around in my pelvis. What is that? We can tell you what that is. Pelvic congestion syndrome. Pelvic congestion syndrome, also known as varicose veins. It means you have large swollen veins in your pelvis. And in women, it's called pelvic congestion syndrome, and in men, it's called varicocele. Ironically, in men, because you can see it, you can see it, men get treatment very, very quickly for it. But for us women, guess what? You can't see it easily. And so many women with pelvic congestion syndrome, these enlarged veins, are told that it's not real, you know, when it is real. And so Stacy Shannon, one of the writers for the IC Network, our lead writer, I gave this assignment to her, did this fabulous article on pelvic congestion syndrome and all the subtleties and symptoms that can be associated with that. And the thing here is that when pelvic congestion syndrome is very easily treated. And when it's treated, guess what? Bladder symptoms, congestion syndrome will cause bladder symptoms. So if you find these meetings helpful, I would really encourage you to become a subscriber and get our magazine, the IC Optimist. I'm the editor, I'm the lead writer, and then Stacy writes for us, and we bring in other people too. And we do 4 issues a year. Sometimes they're delayed, sometimes they aren't. They were delayed. I was able to get them out pretty quickly with COVID. But once fire season hits for us in the fall, my fall issue is often delayed because we have power outages here. But anyway, this is a great magazine. My goal with these magazines is to give you within 5 minutes something that you can talk to your doctor about, something that you can explore to try to help you understand why you might be having chronic symptoms. You know, it reminds me of another patient on Facebook, and I don't know if she's in here or not, Sue, who's told her story many, many times. Sue was diagnosed with IC. She failed every single bladder therapy. Nothing worked for her. Nothing worked for her. And when she went to pelvic floor physical therapy, because her muscles were tight, it really hurt. And it always hurt in the same spot. And it didn't make sense because normally with pelvic floor physical therapy, muscles just slowly relax and get back to normal, get back to the way they were. And her, that didn't happen. And her muscles kept getting, they kept hurting in this specific spot. And she attended one of these meetings, said, "You are an anatomical mystery to be solved." She asked for either a CAT scan or an MRI, and they found it. They found it. What she had was a growth of scar tissue interwoven in her pelvic floor muscles on her left side, I think on her left side, exactly where she fell from a horse, because she was a very good horseback rider, but she fell many, many times. So again, in her case, bladder therapies were a complete waste of time. Everybody missed it. It was all about tight, dysfunctional pelvic floor muscles with a significant compression, significant scar tissue. And now I haven't talked to her in a while. She was supposed to have surgery, but with COVID, I don't know. So Sue, if you're on here, call me. I'd love to talk to you and see how you're doing. Kim says, "Mine started after hysterectomy. I cannot take estrogen due to hysterectomy. What can you do if you cannot use estrogen replacement?" So if you can't use estrogen replacement, then what you need to do is you at least need to provide coating, protective coating. And so for your bladder, you're gonna want to do something that contains chondroitin. So again, that's going to be Bladder Builder, Bladder Rest, Cysto Protect, Cysto Renew. Those are going to be your favorites, the favorite chondroitin supplements. And then for the outside, if you're having burning on the outside, you're going to want to do either coconut oil, but if you're allergic to coconut, the one thing that we have that I really like is V-Magic. And V-Magic is extra virgin olive oil, avocado oil, sea buckthorn. And sea buckthorn is very calming and soothing. This is about as close to human mucus as you'll find that's plant-based. It's a great consistency. It's not sticky like Vaseline. So this would be ideal. Lovina has a couple of products, but these are more for intimacy. Desert Harvest Aloe has aloe gel. There's an aloe gel you could use, but I really like the V-Magic or the coconut oil, and you can get organic coconut oil pretty much any store. Leanne says, "We're about to have severe thunderstorms, so we're freaking out." Thank you. You guys, if you like the meeting, again, if you find these helpful, please become a member of the IC network, because that's what pays for it. And I need to take a moment and thank our sponsor, which I should have done at the meeting. Pre-Leaf helps to underwrite these meetings. Is the oldest supplement out there. It is a simple calcium glycerophosphate that you can use if you're going to eat something that might be irritating, that might have high acids, or whether you're going to grandma's house and eating her favorite lasagna and you don't want to offend her by not eating her lasagna. You could potentially take a couple of Pre-Leafs and that would neutralize the acid. So Pre-Leaf is a staple in many IC patients' toolkits. It's wonderful. And we have a website called the IC Diet Project that we did for them. I did for them 8 or 9 years ago, that we still are putting new diet articles on and recipes on that you might find helpful. So icdietproject.com. So anyway, there's you go. There's my spiel. So for the people who go through coaching for me, you just got that almost word for word. And I'm going to do a last call for questions, because we've been going for 4 hours and 30 minutes, and I got to go make dinner for my parents. So we're going to make carbonara spaghetti with no tomatoes. It's going to be Italian sausage and parsley. Oh, Dang it, I got to go to the store first and get Parmesan cheese. Okay, anyway, last call for questions, and I got to go run to the store. Beth says, can you help me understand my urine? Why does it always come back from the lab with trace blood and slightly acidic pH? My urine smells like sulfur this last week. What's that? Your urine smell is influenced by what you're eating, as well as your age. You may notice that as you get older, changes. Your pH certainly changes in your vagina, which is why you might be more prone to vaginal infection and things like that. The reason why most IC patients have a little bit of blood in their urine, I can explain that. So let's talk for a moment about it. So if you have a bladder wall injury, so here, hold on a sec. So let's just say you have a bladder wall injury. So here's your injury. There's no protective coating here, right? So urine and bacteria, whatever's in your urine, is now penetrating down into this area. Now, your urothelium is pretty dang smart. It has a lot of signaling in it. And it's signaling to your immune system, hey, we got a problem here. We got a problem here. Something is where it's not supposed to be. So what happens is that your body then sends your army, your white blood cells, to swarm the area to kill whatever invader is there. Because, again, 1,000 years ago, most of the invaders were bacterial. They were living, right? And so your body would send white blood cells in the area to get there. But the white blood cells come through your blood vessels. So how does it get from your blood vessels up here? How do the white blood cells get into this area? And the answer is that your capillaries release them. Your capillaries open to let the white blood cells out. And that also happens to let red blood cells out. And that's why you might have microscopic blood in your urine. Defense mechanism. Now, if you've got estrogen atrophy and it's getting there, you can darn well bet there's a lot of white blood cells swarming in there trying to figure out what's happening. Or if you have chronic infection, or if you had chemo. I think that the tragedy here is for the chemo patients and or for the poor diet patients, there's nothing to kill. It's literally an injury. And you got white blood cells that are desperately looking for something to kill, and there's nothing to kill. It's acid erosion. It's just erosion. And so at least those white blood cells are providing a little bit of defense to make sure an opportunistic infection doesn't happen. But anyway, that's my interpretation based on the reading that I've done as to why IC patients often have microscopic blood in their urine, especially when you flare. Especially if you're flaring from your bladder wall. If you've eaten something that's irritated your bladder, that's going to be happening. It's different from a pelvic floor flare, and that'd be a good research study. Do patients who have a normal bladder wall or tight pelvic floor muscles, how often do they have microscopic blood in their urine? I don't think anybody's ever done a study. It'd be interesting. Tammy says, do you recommend anything to help with relaxing your pelvic floor muscles on your own? There are several things out there to buy, but I'm afraid it will hurt me. Tammy, website, and I showed this earlier. We have the third link is to pelvic floor guided relaxation. If you do guided relaxation every day, you are retraining those muscles to be relaxed. So it's going to be a combination of guided relaxation combined with whatever stretches your physical therapist has told you to do. Your physical therapist might suggest your physical therapist might suggest that you use a wand, but using a wand like this is tricky. It's hard. It's hard to visualize where you're putting it, what it's touching. Again, this book, Breaking Through Chronic Pelvic Pain, is remarkably helpful in helping you understand what muscles you're working on and what you're trying to do. Another book that talks about that is going to be this book series. We have a book, Ending Female Pelvic Pain, and a book, Ending Male Pelvic Pain. This book also has a section on how to use wands and stuff like that. But again, the breaking through chronic pelvic pain, I think, is absolutely fabulous. And here, hold on a sec. Let me just make sure. I don't want that to fall. All righty. Kristen says, has anybody here had gastric bypass or sleeve? Did it help or hurt your IC? Gastric bypass would do absolutely nothing for your bladder other than limiting your diet and potentially traumatizing muscles. On the other hand, you know, you have to remember for people who might be carrying a bit more weight, that weight can put more pressure on your pelvic floor. So losing that weight because of a gastric bypass might actually be helpful over the long run, but I can't imagine or visualize how that could potentially damage your bladder. I think it would. I think your food intake is going to be essential, and making sure you're eating the right food combined with losing the weight and working on those muscles. Jennifer says, is there any connection between overactive mast cells and IC? Yes, there is. That would be another subtype of bladder wall driven mastocytosis or any mast cell disorders. If you've got an overabundance of mast cells on your bladder wall, that could also explain why your bladder might be more painful. Let me go down to YouTube here real quick. Sean says, why is it so much worse at night? It's worse at night because you have the distractions that you have during the day. You know, during the day, you're watching TV, you're talking to people, you're on your computer, you're watching TikTok, whatever. There are distractions that when you're trying to go to sleep are gone. That's just much, much easier to pay attention to the frequency and the urgency and the feeling like, you know, that's just, it just is what it is. I will say that generally nighttime discomfort is often a direct reflection, especially if you're having bladder wall pain, of what you've eaten during that day also. All right, my friends, I'm going to give you your homework. You've got 4 things to do. And we do have 4 things to do. Number one, I need you to spend 15 minutes a day reading about IC or watching a video or something. Come to our website, read a blog, read the magazine. We give a lot of stuff. You know, the entire website's free. It's the largest free archive of IC information in the world. Would you please go read an article a day? And don't just read from us. Go over to the ICA website. Go to others. Come on, we got to improve your knowledge level. Let's get your skill set up there and your knowledge level up there. And seriously, if you don't know where your urethra is and where your urethra is compared to your vagina, I need you to go get a freaking mirror and squat over it and look. You need to know your body. Don't rely on other people to know your body. You need to know your body. Nobody can tell you when you need to pee. You're the only one who can tell you when you need to pee. So it is time to learn your body. Number 2, I need you to do something for your spirit. Because, man, this is tiring. And this 2020 has been a brutal year. Oh, my God. I mean, what else can happen? We are exhausted physically, mentally, and emotionally. 15 minutes a day, do something that will give your spirit a little bit of comfort, whether it is reading a Bible, reading poetry, watching a speaker, taking a warm bath. Do something that will give you some comfort. For 30 minutes a day, I need you to do something for your bladder or your pelvic floor. Come on, 15 minutes a day, do your stretches. Do whatever they told you to do. Come on, 15 minutes. Nobody's asking you for much. You can do 15 minutes. And then last but not least, for 15 minutes a day, I need you to laugh. So the best part about this is, please go watch funny videos or watch a funny show, because remember, laughter modulates pain. So the more you laugh, the more you will improve your pain levels. And that is the truth. That is about how your body processes pain. And so let's bring some laughter into your daily life too, okay? All right, my friends, it's been a wonderful day. I'm so glad I recorded this because I'm going to take pieces of it and make some videos from it. It was great to see you. I will see you again next Sunday. Wait, is next Sunday July 4th? Hold on. No, next Sunday is July 5th. And I'm going to make you ill. So here's the thing, as I've got a whole bunch of back issues of the IC Optimist magazine, and I'm sending packets of them out to anybody who wants them because I'm trying to get rid of them. And so I've got back issues going back for years. If you are interested in getting a packet of 5 or 6 or 7 magazines, all you need to do is email me, icnetwork@mac.com, and I would be more than happy to send you a few of the older back issues, because I don't want to recycle them. They're good. They might be helpful. And then also, if you send me an email, icnetwork@mac.com anyway, I'm going to do a surprise giveaway to 2 people. And I'm not going to tell you what it is, but I think you're going to like it. And so if you would like to be in for just a little surprise, send me an email, icnetwork@mac.com. All right? All right, you guys, big giant hugs from me, big giant hugs from me. You are strong. You are going to get through this, and we are going to see you next Sunday. Have a good one. You're welcome, Annie. You're welcome, Tammy. I wish you all the best. All right. Goodbye, Facebook. All right, YouTube. I'll see you later.